start recording, and the recording has started. So today we do have a lot of material to get through. I believe there's about 119 slides. So thank you for those that are attending online as well as those in person. We really appreciate it. And we hope that this will let you guys be successful with your attempt, your second attempt on this exam. So we are just literally going to highlight the main points on the slides so we can get through everything today. Again, for those online, feel free to ask questions and you can write in the chat. I will keep an eye on that so that way I can make sure to address your questions. All right, so Lindsay is going to start us off with the review. I'm going to pull up the chat here and we're going to get going.
So I'm going to teach the antepartum and the labor and delivery. Brittany is going to do postpartum and newborn. We are going to start off with emergency contraception. We're going to do a few contraception things before we get into actual pregnancy. So if we're looking at the morning after pill, this is going to be what we call Plan B or emergency contraception. So this is the levonorgestrel emergency contraception pill. You can get this at the pharmacy. You don't need a prescription for it. Anybody can go and get it. The things that you need to specifically know that you're going to teach your patients about if they're going to take this is it has to be 72 hours after intercourse. If you take it after 72 hours, it is not going to work. Oh, sorry.
Yeah, okay. Yeah,
you want to take an over-the-counter anti-nausea medication because it is a high dose of progesterone. Sometimes that can make you nauseous. So you want to take that an hour prior to each dose. And then you're going to be evaluated for pregnancy if you do not get your period. If you take it and you get pregnant, taking it is not going to harm your pregnancy. It will prevent you from getting pregnant within the 72 hours, but it's not going to hurt your pregnancy if you are in fact pregnant. So if you don't get your period at the end of the 21 days, you do need to go in because you could be pregnant. And then whenever we give this, we do want to tell our patients to start to use actual contraception. So that could be condoms, the pill, the Nexplanon, and IUD. And then our contraindication is if the patient is pregnant or has abnormal undiagnosed vaginal bleeding, because we're worried that there could be an ectopic. When we are looking at doing combined oral contraception, so this is going to be birth control pills that contain both estrogen and progesterone. These work by suppressing ovulation. They thicken the cervical mucus to block semen, and then they alter that uterine lining and they make it so that the fertilized embryo would not be able to implant. When we're talking about our risk factors and who we do not want to take birth control that contains estrogen, this is going to be anybody who has cardiovascular risks. So this is going to include if they have a history of a thromboembolic disorder, so a patient who's had a previous DVT, or maybe they have a known thrombophilia, so they've got factor V, Leiden, von Willebrand's. If they have a history of stroke, heart attack, coronary artery disease, gallbladder disease, and that's because it's going to interfere with the absorption of the medication. If they have liver disease, liver tumors, cirrhosis, headache with aura, so migraine with aura, diabetes with vascular involvement, if they're hypertensive, if they are smokers, obese, over the age of 35, or if they're breastfeeding in less than 6 weeks postpartum. A lot of our adverse effects, headache, nausea, breakthrough bleeding, fluid retention, breast tenderness, these are going to be heavily influenced by estrogen versus increased appetite, fatigue, depression, oily skin and scalp, and then hair growth are going to be from progesterone. So ATI loves to talk to you about diaphragms, which is kind of hilarious because in 17 years, I've never given a patient a diaphragm. But what the diaphragm is it is a dome-shaped silicone cup that's going to fit snugly over the cervix. In order to make this effective, you're going to need to instruct your patient to put spermicidal cream or gel into the dome and around the rim. So patient education, this is where ATI and NCLEX is typically going to test you on it. And that is going to include that it has to be fitted by a medical provider. It needs to be replaced every 2 years. It's going to need to be refitted if you have a weight fluctuation of 20%. So that would be a weight gain or loss of 20%. If you've had abdominal pelvic surgery and after every pregnancy. So you really need to remember, I feel like this would be a really good multiple choice question on ATI when you need to have it refitted. That's going to be every 2 years, after pregnancy, weight gain or loss of 20%. And then if you have any abdominal or pelvic surgeries. You need to instruct your patient on proper insertion. This is going to be to put that spermicidal jelly around the rim and inside the dome. It can be placed up to 4 hours prior to intercourse, 6 hours prior to intercourse. And it must stay in place for 6 hours after, but no more than 24. That is going to be a test question all day, every day. You need to put it in 6 hours early, and then it has to stay in for at least 6 hours afterwards, up to 24. Each time you use it, you need to replace the spermicide. You do want to empty your bladder prior to placing it to decrease pressure on the urethra. And then you want to wash it with mild soap after each use. So the diaphragms prevent pregnancy, but it's not going to prevent STIs. The longer you have it in after intercourse, the higher your risk of toxic shock syndrome. Okay, so let's do some practice questions. Okay, a nurse in a health clinic is reviewing contraceptive use with a group of clients. Which of the following client statement demonstrates understanding? A water-soluble lubricant should be used with condoms. B, a diaphragm should be removed 2 hours after intercourse. C, oral contraceptions can worsen a case of acne. And D, a contraceptive patch is replaced once a month. The answer definitely there. It's okay. Yeah.
No.
We're gonna just go through, pick the answers, and then we're gonna go through the answers and then look at the rationale. So what do you guys think? You want to say A? So a nurse is instructing a client who is taking an oral contraceptive about manifestations to report to the provider. Which of the following would the nurse include? Reduced menstrual flow, breast tenderness, shortness of breath, or increased appetite? Yep, so alarming side effects that you want. Yep, it's in the slideshow. Thoughts?
If you log in, do you guys, the Teams meeting that I did, if you guys log into that, it's on there. You should have been like, I emailed a link to it. So you can always log in and have that pulled up on your computer as well.
So just to keep things rolling, do you guys feel like the ABC answer would be the best one? Yeah. Yep, okay, perfect. So we're gonna say shortness of breath. The nurse is in an obstetrical clinic is teaching a client about using an IUD for contraception. Which of the following statements made by the client indicates understanding of teaching? A, an IUD should be replaced annually during a pelvic exam. B, I cannot get an IUD until after I've had a child. C, I should plan on regaining fertility 5 months after the IUD is removed. And D, I will check to be sure the strings of my IUD are still present after my period. And it's okay if you guess wrong because we're going to go through. I just want you guys to take a guess so that we've got something to go with. D, perfect. A nurse is teaching a client about potential adverse effects of the implantable progesterones. Which of the following adverse effects should the nurse include? Tinnitus, irregular vaginal bleeding, weight gain, nausea, and gingival hyperplasia.
That's a mouthful.
It is. So select all of them that apply. Which ones are caused by progesterone? B, what else? D, any else that you want to choose? If not, that's okay. We'll go to the next one.
Yeah.
Oh,
No, I can, you should put your computer by me. Is that possible?
Yeah.
And then I can do both.
A nurse is in a clinic teaching a client about a new prescription for a progesterone. Which of the following information should the nurse include in the teaching? A, weight fluctuations can occur. B, you are protected against STIs. C, you should increase your risk or increase your intake of calcium. D, you should avoid taking antibiotics. And E, irregular vaginal spotting. Select all that apply. A, what else?
C.
C, what else?
I got an E on here too.
Okay, so now we're going to pull up the answers and we're going to talk about why each answer is correct. Well, this is going to, we're doing this to help you guys understand which questions to, what's answer options to choose, especially if you don't know. So when we're looking at the first question was about what teaching education should be included in evaluating their understanding. The answer is going to be that condoms need to be used with water-soluble lubricants. We know that a diaphragm needs to be removed no sooner than 6 hours. The question said 2 hours. We do know that acne is not necessarily reduced when taking oral contraceptions, and that contraceptive patches are replaced weekly, not monthly. So for question 2, when we're looking at the adverse effects that you need to report to your provider, reduced menstrual flow is usually a beneficial side effect of taking contraceptions. Breast tenderness, that is a normal expected side effect. Shortness of breath. We are worried about a DVT that has embolized and became a PE. So if you had no idea by looking at your answer options, if you see an airway, breathing, circulation answer option, it's likely going to be the correct answer, especially if you have no idea what the question is asking. Maybe you're looking at the question and you're like, did I ever even read that disorder in nursing school? If there's an ABC answer option, choose that. And then again, increased appetite is an expected side effect. So when we're talking about proper IUD use, it is replaced in America, we now have upped it to every 7 years. ATI is likely going to say 5. You do not have to have had a child prior to being inserted. Fertility returns immediately. The client needs to check for the presence of strings after their period. We just want to make sure that you check your strings monthly so that you know if it's fallen out or not. In real life, I've never seen an IUD fall out in 17 years. It's not very common.
The strings can go.
They can go up, but you might not feel them, but I've never actually seen them fall out. So what are side effects of your implantable progesterones? This is going to be your Nexplanons and your progesterone IUDs. And this is a select all that apply. So tinnitus is ringing in the ears. This is not a side effect of progesterone. Irregular bleeding is. Some people have irregular bleeding with these methods. Weight gain can be possible. Nausea can be possible. And then the gingival hyperplasia is not part of progesterones. And then with our last question, so we're putting them on, this is the depot injection. If we put them on the depot injection, we expect them to have weight fluctuations. They're going to gain weight. They do need to take calcium and vitamin D because high doses of progesterone can leach calcium from the bones. Antibiotics don't affect the progesterones. And then it can cause intercycle bleeding. Questions on those at all? Nope. Okay, cool. Go to our next slide. So we can go into that. And then you go into this. So just log into Teams and then go onto your calendar into this one, and it will be on there. Okay, our presumptive probable positive signs of pregnancy. Again, this is an ATI and NCLEX question all day, every day. Your presumptive signs are subjective things that the patient reports. She tells you she has nausea. She tells you she's fatigued. She tells you she hasn't had a period. It's not anything we can actually measure. Our probable signs of pregnancy are things that the woman feels and things that we can possibly see or feel. So this is going to include Goodall's, Chadwick's, and Hager sign, allotment, fetal outline felt by the examiner. So if I'm touching her abdomen, if I'm doing Leopold's, I feel something that is roughly the shape and or size of a fetus, and then a positive pregnancy test. A positive pregnancy test is not a positive sign because urine pregnancy tests could be a false negative or a false positive. And even blood HCG tests are not a positive sign because there are certain cancerous tumors in the body that can secrete HCG. So the only 3 positive pregnancy signs that exist are I can see the baby on ultrasound, I can hear the baby with a fetal monitor, or I can feel the baby move. If you look at our probable sign of the fetal outline being felt, you could have a uterine fibroid that is roughly the size and the shape of a fetus, but a fibroid does not move. So feeling fetal movement is going to be a positive sign.
I always say just memorize the positives, okay? And then know that presumptive, like Lindsay said, is stuff that we're not going to be able to assess. And if it's not in the positive category and it's not in presumptive because it's something that she would just say she's feeling that we can't examine, then it's likely going to fall into that probable category. Okay. So that's a really easy way to think about how to decipher between the 3 of them. Does that make sense?
Okay, so we are going to do calculating the due date. We're just going to do 2 examples off of the group of questions on here because you guys can do more of them on your own. But the formula, if we're using Nagel's rule to calculate due dates, you're going to take the patient's LNP, which, what is an LNP? It's the first day of your last period. You're going to subtract 3 months, add 7 days, and that is going to get your due date. Now, I know it seems redundant to write it out like this, but if you write it out the way we're going to practice writing it out, you will get the right answer. When you try to do the math in your head, it's easy to be off 1 day or not change your year correctly. So let's go to the next one.
Okay.
Okay. So during a prenatal appointment, a patient tells you that her last menstrual period was May 21st, 2022. Based on Nagel's rule, what is her estimated date of delivery? So her LNP is May 21st, 2022. So the first thing, what's the first thing you want to do? Subtract 3 months, and then what are you going to get? You'll get February 21st. And then what do you want to do? Add 7 days. And you're going to get February 28th. What year? 2023. So you get 2023 because when we look at our LMP, May is already after January, right? So we're already into 2022. And then when you come down to the month that she's due, that's February. So we've already crossed January. It gets us into the next year. You have to make sure that you look at your year because you're going to have an answer option, which is obviously February 28th of 2023. But another answer option is going to be February 28th of 2022. They will do that purposefully to mess you up. Okay. During a prenatal appointment, a patient tells you that her last menstrual period was November 25th of 2022. So what was her LMP? November 25th? Yep. November 25th of 2022. So if you subtract 3 months, what will you get? Yep, you're going to get August 25th. And if you add 7 days, what will you get?
This is where you need to know how many days are in a month,
Yep.
right?
Yes. So there are 31 days in August. So the correct answer is September 1st. And then have we crossed a year? Yes.
Think about it.
Yes.
It's at the end of 2022.
So we have crossed into 2023. So you have to know how many days are in each month because again, they're going to have the correct answer, which is September 1st of 2023, but it's also going to have September 2nd of 2023. And it's because it's trying to see if you know that there were 31 days in August instead of 30. Perfect.
Isn't there like a knuckle thing that you can do?
Yeah, there are never 2 31-day months in a row.
Okay. Yeah, I thought there was like some sort of strategy. Okay.
Okay, so when we are doing our G's and P's, we're going to remember that gravida is the number of pregnancies you've had regardless of outcome. And then parity is the number of pregnancies that has reached 20 weeks regardless of outcome.
Oh, guys, July and August have 31 days back to back. So okay. Good to know. Yep.
Perfect.
Good catch.
Good
catch.
Okay, so gravida is the number of pregnancies regardless of outcome. Parity is the number of times the woman has reached 20 weeks regardless of outcome. So again, the easiest way to do this so that you make sure you have the right answer is to write it out.
Oh, from our one. There's dry weather. That one should be, oh, here. This one's partially dry.
Okay, so we are going to do G, T, Cal. Okay.
Okay.
Okay, a patient is pregnant with twins and has a 5-year-old son at home. The patient has had no miscarriages or elective terminations. The patient had her son at 39 weeks. What is her current G's and P's? So how many times has she been pregnant? Twice. Her twins and then this pregnancy. How many term deliveries has she had? 1.
Good.
How many preterm deliveries? 0. How many abortions? 0. And how many living children does she have? 1. So she is currently a G what? 2, P what? 1, 1, 0, 0, 1. So she's pregnant with twins, correct? So let's say she delivers her twins at term. What will her G be? Her G will be 2. That doesn't change. What will her term be? 2. Even though she's giving birth to 2 children, because she's giving birth to twins, it is only one birthing experience. So her term is going to become 2. How about her preterm? 0. Abortion? Living? 3. So she's going to turn into a G2 P what? 2003. So when we have a twin pregnancy, the way we see it reflected is if you're looking at her living children, she has more living children than she's had pregnancies. She's had more living children than she's had deliveries. Does that make sense? Okay, let's do another one. A patient comes in to see you for her first prenatal visit. Her dating ultrasound shows a single viable intrauterine pregnancy at 6 weeks, 5 days gestation. The patient's obstetrical history includes 2 children at home, born at 37 and 40 weeks, 1 miscarriage at 9 weeks, and 1 elective termination at 12 weeks. What is her current gravida and para? So let's write out our G, D, F. So how many pregnancies has she had? She's currently pregnant. How many living children does she have? 2. So those were each pregnancy. And then how many abortions has she had? 2. So she's a G5. How many term deliveries? How many preterm? 0. How many abortions? And how many living? 2. So currently she is a G5 P what? G5 P2022. So let's say she gives birth at term. And this is a singleton pregnancy. So her G is going to be what? 5. Her T will be, her P will be, her A will be, her living will be. So she is going to become a G5 P what? Yep, so she'll become after delivery a G5 P3023.
She just gave birth for the 2 weeks.
This one, she's only has a single pregnancy. Yep. She doesn't have twins on this one. Yep. So again, I know that sometimes it feels redundant to write it out this way, but if you write it out this way, you're going to get the questions correct. Okay, so when we're looking at maternal changes, when you are pregnant and newly postpartum, you have 50% increased circulating blood flow. Okay, that 50% increased circulating blood volume does a lot of things to your body. If we're looking at the cardiovascular system, it's okay if you're reading this and you're thinking, I don't necessarily remember what cardiac output is or stroke volume is. I'm going to give you a couple little hacks. If you have 50% increased circulating blood volume, all of your volumes are going to be going up. Okay. When we look at an increase of cardiac output, if you have more blood, is there more blood in your heart that has to get out? Yes. Stroke volume is a unit of measurement. You already know you have more blood, so would it make sense that you have more stroke volume? Yep. You have an increase in heart rate. Your heart has to beat more often to get all of that blood to your, through your body. And then we have a decrease in blood pressure. When you have 50% extra circulating blood volume, the heart doesn't have to work as hard to get it to go where it needs to go. If you don't remember that, you guys know that if your blood pressure goes down, what does your heart rate always do? Goes up. When we're looking at the GI system, this is heavily influenced by the progesterone hormone. Progesterone is going to cause a decrease in gastric emptying. So if you're eating food and it's not getting through your stomach as fast, you get reflux, and that's where we see an increase in heartburn. GI motility is at the colon. The intestines aren't passing through stool as often. And we see in pregnant women that they have constipation from that usually. When you're looking at your respiratory system, remember you have 50% increased circulating blood volume. So again, tidal volume, vital capacity, and residual volume. If you don't know those words, it's okay. If you have 50% increased circulating blood volume, do you have more blood that you have to send from your heart to your lungs? Yeah, you have to oxygenate more. So we're going to see an increase in our volumes, which is going to be tidal and residual. When we're looking at vital capacity, think about when you're pregnant, the uterus is pushing on the diaphragm. You don't have as much room for your lungs to fully expand. So the capacity is limited or decreased. Residual volume, think about a pregnant woman. Can she take a big deep breath in and then do this for a very long period of time? No, she can't. It's hard for them to blow out air, for any sustained period of time. So you have air left over. So you've got that increased residual blood volume or residual volume.
Can you do that one more time? No, just
So total side note. The other day, the mannequin, the sounds weren't working. So I had to do all the sounds of the contractions. And I literally thought I was going to pass out because I was hyperventilating as, a labor patient would. Oh, kidneys. If you have 50% increased circulating blood volume, are you perfusing more blood to your kidneys? Absolutely. If you are perfusing your kidneys more, are you going to pee more? If you pee more, your GFR goes up. If you pee more, you are clearing more creatinine through your urine, and you'll see your creatinine clearance rate go up. If you have 50% increased circulating blood volume, will you have more plasma? Will you have more red blood cells? Will you have more white blood cells? Are you at higher risk to clot? Yes. Okay, this talks a little bit more specifically about each body system and how it changes in pregnancy. I'm not going to go through all of this because we talked about a lot of it just in that last slide, but this has got the language. This is straight from the Maternal ATI book. So read that on your own just so that you can kind of be familiar with how they word things. So when you're talking about body image changes during pregnancy, there were a handful of these questions on the dynamic quizzes. So things that were specific in the outline is that in the first trimester, psychological changes are not, or physiological changes are not obvious. So your first trimester, you're not necessarily showing. And most patients are excited to get to the point where they actually look pregnant instead of just bloated, right? The second trimester is when we have rapid enlargement. You go from not showing at all to like feeling really big. And then you have enlargement of the breasts. This can affect mom's mobility. It's harder for her to get in and out of bed, up the stairs, things like that. Skin changes, we're going to have stretch marks. We are going to have that hyperpigmentation. And then we have the linea nigra. And then patients in this period can be easily set off of balance because think about the bigger belly and the bigger breasts. It can make your center of gravity uneven. You have leg cramps and fatigues. In the third trimester, fatigue, back pain, difficulty to sleep increases. I want you to specifically see that these changes may lead to negative body image, and some patients may make statements of resentment to their pregnancy and express anxiousness for the pregnancy to be over soon. I saw this sentence like 25 times in this chapter for ATI. So I would really pay attention to the fact that in the third trimester, women are so uncomfortable that sometimes they're just like annoyed they're even pregnant.
Yeah, you'll get people coming in at like 36 weeks, like, can you induce me? Because they're just
miserable.
Ready.
They're over it. Okay. Our practice questions for this. A nurse is caring for a client who is pregnant and states that their last menstrual period was April 1st. I don't think we need to do another one of these.
No,
We did this on.
we'll skip that one.
I don't think we need.
Number
Where do you want to go?
3, what's this
Number
one?
3.
Yep, number 3 we're going to be at, guys.
A nurse is reviewing the health record of a client who is pregnant. The provider indicated that the client exhibits probable signs of pregnancy. Which of the following signs should the nurse expect? So remember, we go presumptive, probable, positive. So our probable signs, we've got Montgomery glands, Goodall sign, allotment, Chadwick sign, and quickening. So which ones of those do you think are going to be our probable signs of pregnancy? We know for sure that Chadwick's is going to be one.
Got some people typing here, so I'll share once they type.
So remember that Goodall's, allotment, and Chadwick's are all kind of in that list together. So that would be probably should have wrote that down further. What are Montgomery glands? Okay, if you don't know it. So Montgomery glands are when you look at a pregnant woman, the nipples increase in size and then the color gets darker. It makes it easier for the baby to find the breast to latch on. But the Montgomery glands are those little circles that will be all around the areola. They're glands that the breast secretes. So that would, do we want to add that? Is that something you can see? That's okay. You can move on. A nurse in a prenatal clinic is caring for a client who is pregnant and experiencing episodes of maternal hypotension. The client asks the nurse what causes these episodes. Which of the following responses should the nurse make? So the maternal hypotension, is this because there is an increase in blood volume? This is because the increase of pressure from the uterus on the diaphragm, the weight of the uterus on the vena cava, or due to increased cardiac output. So which one of those is going to make mom have hypotension? That could make her dizzy.
Even if you don't know, take your best guess.
Anything?
I got a C here.
See? Okay.
Yep.
A nurse is in a clinic who receives a phone call from a client who would like to be tested in the clinic to confirm pregnancy. Which of the following information should the nurse provide to the client? You should wait until 4 weeks after conception to be tested. You should be off any medications for 24 hours prior to the test. You should be NPO for at least 8 hours, or you should collect urine from the first morning void.
I have a D.
What's the answer?
And I have an A as well.
A, okay. So we're going to start at the third question. Montgomery glands are presumptive. The opposite. So for 3, Goodall's, allotment, and Chadwick's, those are signs of probable. They're not presumptive because we can see them, but they don't fit into the positive category. When we're looking at 4, the reason that mom will get these bouts of hypotension is C. That's when the weight of the pregnant uterus and the baby, when mom is laying on her back, it pushes on the inferior vena cava, which is going to decrease mom's circulating blood flow, which will make her hypotensive and feel dizzy. And then for 5, the correct answer is that you want to use the morning void. It's going to have the highest amount of HCG in it when we want to test. Somebody said A, we don't need to wait that full 4 weeks because we do have those early EPT tests where you can test like 7 to 8 days prior to you getting to your missed period, which would be that 4 weeks. Okay. So when you are looking at answering questions on ATI about nutritional needs, this slide is exactly what you need. So a woman who is pregnant in the first trimester, your nutritional needs, we're looking at roughly 300 calories a day. Sometimes that's not hit because mom might be nauseous, she might be vomiting. In the second trimester, you need to increase your daily intake by 340 calories. In the third trimester, it's 452.
So exact.
Compete these or put these in your memory because this is exactly what ATI says. We need to look at iron intake because it is very common to have anemia in pregnancy. We want it to be 11 to 12. You want to have 6 to 8 glasses of water each day, which would be roughly 2 to 3 liters. Protein, you need 71 grams of protein daily, and then your calcium recommendation is 1,000 milligrams. This is what you want to commit to memory. Foods that you need to avoid in pregnancy. So dairy products have to be pasteurized. So that means no raw milk, no pasteurized soft cheeses. This is going to be like goat cheese. Seafood and sushi. Cold cuts. If you want to have like a turkey and cheese sandwich, you need to instruct your patient to put the lunch meat in the microwave until it steams. Alcoholic beverages. Caffeine, they need to restrict it to under 300 milligrams a day. They don't have to get rid of it completely, but they need to lower their caffeine intake to 300. And then weight loss diets or supplements aren't safe in pregnancy. So when you are counseling your patient on prenatal vitamins, they need to take a prenatal vitamin because this is going to contain folic acid and iron. Folic acid is the man-made version of folate. We find folate in foods. Folate is naturally occurring. We make folic acid to put in vitamins. It's the synthetic form of folate. What does folic acid prevent in pregnancy? Neural tube defects.
Good job.
So by mom taking folic acid in pregnancy, she decreases her risk of neural tube defects, which is going to be things like spina bifida. The folic acid amount is either 0.4 to 0.8 milligrams. And that's typically what's just going to already be in a prenatal vitamin. Vitamin D, we want 600 international units, 200 to 300 milligrams of omega-3 fatty acids. Vitamin A, if you are deficient, you can do 10,000 international units. And vitamin C, 85 milligrams is suggested.
For your folic acid too, ATI talks about you guys as 400 kind of being the standard dose that we would do.
But if somebody had a child with a previous neural tube defect, then we would up it to the 800. Okay, so just a heads up with that too.
And again, these are the very specific ATI ones.
Yeah.
Same with the weight gain in pregnancy. This comes straight from the book. The big thing that you want to understand is that if you are underweight going into pregnancy, you have a higher weight gain allowance versus if you are overweight, you gain less. But the 1.5 pounds per month during the first trimester and the 1 pound per week during second and third trimester, that is what I would memorize. Dietary risks and complications. So this slide, again, comes straight out of ATI, and it's going to talk about any age, cultural, education, socioeconomic issues that can affect pregnancy. Specifically thinking that if you have an adolescent, so a teen pregnancy, they're likely going to have poor nutrition. We know teenagers aren't real great eaters of healthy foods. Typically, they're going to have a diet that's low in vitamins, protein, and iron. And they may not take their prenatal vitamins every day like they're supposed to. Vegetarians were worried that they're going to have decreased protein, calcium, iron, zinc, and vitamin B6. Nausea and vomiting in pregnancy can affect this. Anemia, eating disorders. If mom has a history of anorexia or bulimia, is gaining weight throughout the pregnancy going to be difficult for her? Yeah, absolutely. Pica. Pica is when you want to eat non-food items. This could be dirt, tire treads, chalk, all sorts of things. It's typically linked to anemia. And then if the family is low socioeconomic, they might not have money to buy healthy foods. If mom herself has PKU, this is one of those genetic disorders that we screen for on the newborn screen. If mom has PKU, she has to start the PKU diet 3 months prior to pregnancy and then do that throughout the pregnancy. Otherwise, if she's not on her PKU diet, the phenylalanine levels that she would have being elevated would be detrimental to the baby. We're going to measure her levels throughout the pregnancy. This seems super specific. It's probably because it's on the test. Diabetes, both pre-existing and gestational, are complications where they are going to need to monitor their intake of typically carbs. We have them count carbs. We want them to keep their sugars within target range. They need to limit desserts and sweets that are high in sugar. And then we're always going to have them meet with a dietitian. When we're looking at hyperemesis, the big thing that you need to commit to memory is that part of the diagnostic criteria is that you are losing weight. So you can have pretty bad nausea and vomiting in pregnancy, but if you have hyperemesis, you actively lose weight. You're not going to slowly gain or stay the same. You're going to lose weight. And then you are so dehydrated from the vomiting that you have electrolyte imbalances. If we have imbalances in things like potassium, sodium, calcium, what can happen to you? You can die, right? We know, especially our potassium. If our potassium gets out of whack, you die. So a lot of times these patients have to be hospitalized inpatient to get things like TPN and lipids. Should we keep doing practice questions? Are the practice questions helpful?
Yeah.
They are? Okay. Okay. So a nurse in a prenatal clinic is providing education to a client who is 8 weeks gestation. The client states, I don't like milk. Which of the following foods should the nurse recommend as a good source of calcium? Dark green leafy vegetables, deep red or orange vegetables, white breads and rice, or meat, poultry, and fish?
Best guess.
A.
I got an A on here too.
I'm going to say in general, if it comes to a nutrition question and there is dark leafy green vegetables, that's going to likely be your answer.
I did also get a D, so we can talk about that as well.
A nurse in a prenatal client or clinic is caring for 4 clients. Which of the following clients' weight gain should the nurse report to the provider? A 4-pound weight gain in the first trimester, an 8-pound weight gain in the first trimester, a 15-pound weight gain in the second trimester, or a 25-pound weight gain in the third trimester?
This is the question.
That I didn't like, yeah.
I can see what you mean now. What are your thoughts? Best guess.
I think this one is
This one's tricky, you guys. I think we put it on here because when me and Lindsay reviewed it, we didn't like the way it's worded, but it's an ATI, so we want to talk about it still.
Is it D?
D, we got a D, and then I also got a B.
Okay, so we got to get a D. Okay. A nurse is in a clinic teaching a client of childbearing age about recommendations for folic acid supplements. Which of the following defects can occur in the fetus or neonate in result of a folic acid deficiency? Iron deficiency anemia, poor bone formation, macrosomic fetus, or neural tube defects?
I have a D.
A nurse is reviewing a new prescription for iron supplements with a client who is 8 weeks and has iron deficiency anemia. Which of the following beverages should the nurse instruct the client to take with the iron supplements? Ice water, low fat or whole milk, tea or coffee, or orange juice?
Got another D too. Perfect.
A nurse is reviewing postpartum nutrition needs with a group of clients who have begun breastfeeding their newborns. Which of the following statements by a group member indicates an understanding of teaching. I am glad I can have my morning coffee. I should take folic acid to increase my milk supply. I will continue adding 330 calories per day to my diet. I will discontinue my calcium supplements because I don't like milk.
Or I will continue.
Or I will continue my calcium supplements because I don't like milk. Sorry.
We got an A and a B, I think.
A and B.
Is that what I heard? Yeah.
All right. So question 1 is our dark leafy green vegetables. They have a lot of calcium in them. Question 2, the correct answer is B. The nurse should be concerned about a weight gain that has exceeded the 3 to 4 pounds that's expected in the first trimester. So question A, 4 pounds, that's normal. Question B, I think was 8 pounds, which would be twice what we expect. Question C, or answer C, the
Appropriate weight
is
gain.
appropriate. And then question D, it means that they are in the 3rd trimester and they've gained a total of 25 to 35 pounds.
Yep. So it's the total weight,
It's
not just
in that trimester.
And that's
why it's screwy.
And that's why we didn't like it, because they didn't make that clear. So just think about that weight gain, that overall weight gain that a pregnant patient should have if you get a question like that. And if that's matching and they have an option like that, just know, okay, that's likely not the correct answer then. Okay. I know those ones are tricky with ATI.
We know that folic acid is going to help prevent neural tube defects. You guys all got question 4, that drinking something with vitamin C, that's going to help increase your absorption of iron. And then we still need moms to continue their calcium supplements, especially if they're not getting enough dietary calcium. All the things that mom, all of her vitamins, her minerals, her calories, when baby is breastfeeding, they leach them away from the mom. So mom needs to make sure that she's replacing her calcium. Do we need a 5-minute break here?
We have been about an hour in,
Yeah,
so
let's take
let's do a 5-minute break, okay? And we'll come back and hit this slide. For those of you online, I did just forward through an email that also has the PowerPoint mode of what we're presenting today. So please just check your emails and you should see that come through here shortly. Those in person, did you guys find it? Awesome. I see some heads shaking, yes.
Okay, so this slide, I don't want to spend a whole bunch of time on it. I feel like you guys know what sorts of things you need to know when you're admitting a patient. And then the prenatal visit schedule, this is how frequent their visits are and what is done at those visits. Okay, so your emotional changes of pregnancy, emotional lability. This is expected. Many patients will go through unpredictable mood changes, increased irritability, tearfulness, and anger alternating with feelings of joy and cheerfulness. This is often hormonal changes. Feelings of ambivalence. Patients may feel ambivalent about their pregnancy. This is normal. And this is typically going to occur in the first trimester and resolves prior to the third trimester. And you can have feelings of ambivalence even if it was a planned pregnancy. This slide, there's a lot of questions on the ATI that talk about what are reportable findings. So in the first trimester, signs of infection. So this could be burning with urination if we're thinking of UTI, severe vomiting, we're thinking of hyperemesis, diarrhea could be infection, abdominal cramping or bleeding. You should not have cramping or bleeding in the first trimester. Second and third trimester, we're looking at a gush of fluid prior to 37 weeks. We're worried that your bag of water is broke. Vaginal bleeding, you can have normal bloody show when you're in labor. And that's going to be like pink tinged mucus, but you should not have period-like bleeding at any time in your pregnancy. Abdominal pain, changes in fetal activity. Once your baby starts moving and you feel them move every day, they need to move every day. Again, persistent vomiting, fever, dysuria, blurred vision. We're worried about things like preeclampsia, same with severe headaches, swelling, epigastric pain. Concurrent occurrence of flushed, dry skin, fruity breath, rapid breathing, increased thirst and urination, and headache. These are signs of hyperglycemia versus concurrent feelings of clammy, pale skin, weakness, tremors, irritability, and lightheadedness is hypoglycemia. Remember the hyper and hypoglycemia warning signs. Okay, a nurse is teaching a group of clients who are pregnant about measures to relieve back pain during pregnancy. Which of the following measures should the nurse include? Select all that apply. Avoid any lifting, perform Kegels twice a day, perform the pelvic rock exercise every day, use proper body mechanics, and avoid constrictive clothing. What do you guys think? Does a pregnant person need to avoid all lifting? No. Kegel exercises or pelvic floor exercises, is that going to help with back pain? Do you think? Perform the pelvic rock exercise every day. Yeah, that should help. Use proper body mechanics. Avoid constrictive clothing. So we're thinking C and D. A nurse is caring for a client who is pregnant and is reviewing manifestations of complications. The client should properly report to the provider. Which of the following should the nurse include? Vaginal bleeding, swelling of the ankles, heartburn after eating, lightheadedness when lying on her back. This is not a select all that apply. Bleeding.
I have an A too.
Sorry. A client who is 7 weeks gestation is experiencing nausea and vomiting in the morning. Which of the following information should the nurse include? Eat crackers or plain toast before getting out of bed. Awaken during the night to eat a snack. Skip breakfast and eat lunch after nausea has subsided. Eat a large evening meal. A.
Okay.
A nurse is teaching a client who is 6 weeks of gestation about common discomforts of pregnancy.
Which of the following should the nurse include? Select all that apply. So what are our common pregnancy discomforts? Breast tenderness, urinary frequency, bloody noses, dysuria, epigastric pain. So is breast tenderness common? Yeah. How about urinary frequency? Yep. How about bloody noses?
Yes. I have a yes.
Yep. Should it hurt to pee? No. And should you have epigastric pain? Nope. A client who is 8 weeks gestation tells the nurse, I am not sure I'm happy about being pregnant. Which of the following responses should the nurse make? I will inform the provider that you are having these feelings. It is normal to have these feelings during the first few months. You should be happy you are going to bring new life into the world. I'm going to make you an appointment with a counselor to discuss your thoughts and feelings. Which one? B. Okay. So we are looking, yep, you guys got it right. A pregnant woman can lift things. Doing Kegel exercises helps the pelvic floor, not the back. So doing those pelvic rock exercises, that's kind of like, think about cat-cow. When you're rocking the pelvis front and back, you are stretching out the low back, which can help with back pain. Proper body mechanics, and then constrictive clothing is not going to change it one way or the other. For question 2, yes, vaginal bleeding. This is a reportable sign. All the other ones are normal. Question C, have them eat crackers or toast prior to getting up in the morning. Question 4, you guys got this right. Breast tenderness, frequency of urination, and nosebleeds are common. They should not have dysuria. That would be a sign of a UTI, and epigastric pain would be a sign of preeclampsia. And then question 5, yes, feelings of ambivalence are normal in pregnancy during the first trimester. Okay, when you are assessing the fundal height, what you need to know is you're measuring from the pubic bone to the top of the uterus. The fundus is the top of the uterus. Once you are 20 weeks gestation, the fundus is in line with the belly button, and it should be equal to how many weeks pregnant you are. So if you are 30 weeks pregnant, your fundal height should be 30. You get a standard deviation of 2. So you can be 2 below or 2 above. So if at 30 weeks, your fundal height to be normal, it could be anywhere from 28 to 32. If you're outside of that standard deviation of 2 above or 2 below, then we're going to do an ultrasound to make sure that you're not having a small or a very large baby. In the beginning, we're going to hear the heart sounds really, really, really low on the pelvis, just like right above the pelvic bone. If baby is head down in the 3rd trimester, we'll hear the heart rate below the belly button. If baby was breech, we'd hear the heart rate above the belly button. A non-stress test. So we're going to use non-stress tests as part of our fetal surveillance if mom goes past 40 weeks gestation. So we put mom on the monitor, the fetal heart monitor, and in 20 minutes, we need to have 2 accelerations. So remember when we learned about fetal monitoring that if the fetus is less than 32 weeks, an acceleration is a 10 by 10. If they're greater than 32 weeks, it's a 15 by 15. That means the fetal heart rate needs to go 15 beats above the baseline for at least 15 seconds. So if the fetal heart rate baseline is 120, it would need to accelerate to 135 and be at 135 for at least 15 seconds to be considered an acceleration. So if your NST is reactive and you are greater than 32 weeks, you need 2 accelerations in 20 minutes. That would be reactive. If you do not have that, you would be non-reactive, and then we're going to do further testing like a biophysical profile. We also use non-stress tests when moms have a complicated pregnancy. So if she has gestational hypertension, preeclampsia, gestational diabetes, anything that makes her pregnancy high risk, we're going to do NSTs. You want to have mom either in a recliner So she's gonna be semi-Fowler's position or maybe on one of her sides. You'll put the monitors on. You're gonna give mom this button to push whenever she feels the baby move. You'll instruct her to do that. And then if you don't get any accelerations in your 20-minute window, you can use the vibroacoustic stimulator, which is this little handheld device. You touch it to mom's abdomen, you press the button and it makes a sound. And that's supposed to, if the baby was asleep, it would wake it up and we should see a acceleration. Yeah, and that's NSTs. A contraction stress test. This drives me nuts that ATI is teaching you these. We have not actually done these in practice for like 15 years. I don't know why ATI won't give it up. But the theory of a contraction stress test is if your NST is non-reactive, we can stimulate you to have contractions because we want to see what the fetal heart rate does in response to these contractions. This can be done with nipple stimulation that can cause contractions. This can be done with IV Pitocin. So you're going to put them on the monitor. You're going to stimulate contractions, whether it's nipple stimulation or Pitocin. And we need to get 3 contractions in 10 minutes. And then what we want to do is observe the fetal heart rate. If we have recurrent late decelerations or recurrent variable decelerations or things like a prolonged deceleration, that would be a abnormal finding, which is a positive contraction stress test. If we have no decelerations when we have contractions, this would be a negative contraction stress test, which is what we want. If the contraction stress test is positive, we're going to do an ultrasound, which is the biophysical profile. Amniocentesis. There's a handful of questions on the amniocentesis. So you need to be able to educate to your patient what it is. You want to explain the procedure, obtain informed consent. You need to have her empty her bladder prior to the amniocentesis. If her bladder is full when we do this, we could accidentally puncture her bladder. You want to explain to her that she's going to feel some pressure when the needle is inserted. She needs to continue to breathe because if she holds her breath, the diaphragm is going to push the baby lower, and then we could accidentally hit things with the needle that we don't want to hit. We're going to monitor mom's vitals, the fetal heart rate. We're going to put her on the monitor for at least 30 minutes. We want her to rest for 30 minutes afterwards. If mom is Rh negative and we do an amnio, what do we need to make sure to do? Give her a ROGAM. And then you're going to instruct her after this procedure that she needs to report fever, chills, leakage of fluid, bleeding from the insertion site, decreased fetal movement, vaginal bleeding, or contractions. And then she needs to rest and drink plenty of fluids for 24 hours post-procedure. Practice questions. A nurse is reviewing findings of a client's biophysical profile. The nurse should expect which of the following variables to be included with the test: fetal weight, fetal breathing movement, fetal tone, fetal position, amniotic fluid volume. So which one of those are on there?
Best guess.
Does fetal weight indicate if baby is oxygenated or not?
No, that's fetal breathing movement. Yes. How about the tone of the fetus? Yes, we want the baby in there with good tone. We don't want them in there floppy. How about fetal position? Does that matter? If the baby's head down or breech, can they be healthy either way? Yep. Amniotic fluid volume. Yes, that is important. A nurse is caring for a client who is in preterm labor and is scheduled to undergo an amniocentesis. The nurse should evaluate which of the following tests to assess lung maturity: the alpha fetoprotein, the LS ratio, I'm not even going to try to do those words, a Kleihauer-Betke test, or an indirect Coombs test. So Alpha-fetoprotein, this is a test that we use if a woman is in preterm labor. The LS ratio is actually the correct answer. A Klein-Howard-Betke test shows that there's been a maternal fetal bleed, and an indirect Coombs test, we use that when we're looking at blood typing and jaundice for baby. A nurse is caring for a client who is pregnant and undergoing a non-stress test. The client asks why the nurse is using an acoustic vibration device. Which of the following responses should the nurse make? It is used to stimulate uterine contractions. It will decrease the incidence of uterine contractions. It lulls the fetus to sleep, or it awakens the fetus.
Good.
Wakes them up. Yep. A nurse is teaching a client who is pregnant about the amniocentesis procedure. Which of the following statements should the nurse include in the teaching? You will lay on your right side during the procedure. You should not eat anything for 24 hours prior to the procedure. You should empty your bladder prior to the procedure, or this test is done to determine gestational age. See, we want her to empty her bladder. A nurse is caring for a client who is pregnant and is to undergo a contraction stress test. Which of the findings are indications for the procedure? Select all that apply. Decreased fetal movement, intrauterine growth restriction, post-maturity, placenta previa, amniotic fluid emboli. Best guess for this one. This one's a little tricky.
This one is a little tricky.
Did I hear A? What else?
Is it A, B, C, and E?
A, B, C, and E we have
All
online.
right, let's look. So we got the questions right for the biophysical profile. Breathing movements, tone, and amniotic fluid volume is part of it. Again, when we're doing the amniocentesis, we're looking at the LS ratio. The acoustic vibration device stimulates a sleeping baby to wake up. We do want the patient's bladder empty prior to an amniocentesis. And then the indications for contraction stress tests is going to be decreased fetal maturity, intrauterine growth restriction, and post-maturity. So we would never do a contraction stress test on a patient with a previa. We don't want them to labor. They have to have a C-section for birth. So we would not want to cause them to have any contractions. And the amniotic fluid embolism, that is a complication of an amniocentesis. So it doesn't have anything to do with a contraction stress test. Placenta previa. So we can have a total previa where the entire cervix is over the cervical, or excuse me, placenta is over the cervical opening. Partial part of the placenta is covering the cervix, or a marginal, also known as a low lying. It's not covering the cervix at all, but it's just right up on the edge of it. You have to have 2 centimeters of distance between the cervical opening and the placenta in order to do a vaginal delivery. Our risk factors for this: increased parity. So the more times a woman is pregnant, the placenta will only ever attach to a fresh area of the uterus. So each time you're pregnant, the placenta attaches to that spot on the uterine wall. The next pregnancy, it has to attach somewhere else and somewhere else and somewhere else. So the more pregnancies you have, the less available uterine surface area there is. Advanced maternal age, any risk factor of pregnancy, advanced maternal age is part of that. Previous C-section, multiple gestation, short interval between pregnancies, tobacco or drug use, and hypertension. So what does a placenta previa look like? Previa is bright red, painless bleeding. Think of P for painless, P for previa. They have an increased risk of hemorrhage, and obviously because if they're bleeding prior to delivery, if you're hemorrhaging prior to birth, are you gonna have a higher rate of hemorrhage after? Yeah. Increased risk of preterm delivery. This is because if you're 34 weeks and you start to bleed, we're going to deliver you by C-section then, so you would be preterm. This is diagnosed by ultrasound. You cannot check a woman's cervix who has a previa. If you do, you could put your fingers up through the placenta. If you poke holes in the placenta, you are going to cause catastrophic bleeding. And then this requires a C-section delivery. So you have a patient who has a previa. What are your nursing cares that you need to do? You need to assess for bleeding, leaking of fluid, or contractions. You want to assess her fundal height, no vaginal exams. You're going to do IV fluids, blood products, and prescribed medications. Typically, if they're preterm, they're going to get betamethasone. That's a steroid that helps mature the fetal lungs. And then you want to have oxygen equipment in the room if there is any fetal distress. Placenta abruption. So when we have a placenta abruption, what's happening is mom is pregnant still, and the placenta has started to detach from the uterine wall. Remember that the baby gets all of their oxygen through the maternal circulating blood volume. If the placenta has detached from the uterine wall, there's no blood going to the placenta through the umbilical cord to the baby. We have 3 different types. There is an occult. So all of the edges of the placenta are still attached, but the center has separated. So if this is the uterine wall and this is the placenta, they should be flush. In an occult or a hidden, you'll see this space in the center of the placenta detach. You're not going to see vaginal bleeding in that one because it's attached all the way around. You can have a partial abruption. So part of the placenta is still attached to the uterus, part has detached. You'll have vaginal bleeding with that. And then you can have a complete abruption in which the entire placenta has detached from the uterine wall. What we're going to see with this is vaginal bleeding. It is painful. Abruption is painful. Remember, previa was painless, but abruption is painful. They're at risk for hemorrhagic shock and DIC. So what sort of labs do you want on a patient who might have a previa, or excuse me, an abruption? We want the hemoglobin and hematocrit because if she's bleeding, she's gonna be low. You want her clotting factors. In an abruption, you would see that these would probably be decreased since she's bleeding. Clotting defects would symbolize DIC. You want to do a cross and type match because she's likely going to need a blood transfusion. And then a Kleihauer-Betke. This is going to show us if there has been maternal blood exposure and fetal blood exposure. So we would know there's an abruption because those 2 are separate. Risks. Mom is hypertensive. That is a risk. Abdominal trauma. Mom's in a car accident. She falls on the ice, lands on her belly. She gets kicked or hit or punched in her belly. Cocaine use. Everybody who has an abruption is going to get a drug toxicology screen done because it is often related to cocaine use. History of previous abruption, smoking, nicotine use, premature rupture of membranes, and then multiple gestation are risk factors. HIV positive patients, this comes literally right out of ATI. So our goal is they're going to be on their antiviral, which is going to be AZT for pregnancy. We want their cell counts to be greater than 500. They need counseling prior to and after. We're going to refer them to a mental health consultant. They might need legal assistance. They might need financial resources. We just need to use standard precautions. It's a bloodborne pathogen. We can't breathe it in. It's not airborne. It's not droplet. It is just touch. So we just need gloves, eye protection, that sort of thing. They're going to have their antivirals prescribed to them. Depending on their cell counts, they might have more than one. You're going to tell them that they need to be up to date on their immunizations because if you have HIV, are you at higher risk for other infections? Yeah, so getting like flu or COVID would be very detrimental. Encourage them to use condoms to decrease exposure to their partner if they're not infected. Review a plan for a scheduled C-section at 35 weeks if their viral load is greater than 1,000. If their viral load is less than 1,000, they can have a vaginal birth. That is super specific. The viral load of greater than 1,000 should be a C-section. Under 1,000, vaginal birth is fine. You want to wear gloves when caring for that newborn after delivery, especially until they have their bath. And then the infant should be bathed after birth before remaining with the mother. Babies of an HIV positive mom need a bath prior to getting their injections of their vitamin K and their Hep B vaccine. Okay, so some specific infections during pregnancy. Gonorrhea is one of those infections that we screen for in pregnancy. You want to provide your patients education on it to decrease their risk of exposure. If your patient is gonorrhea positive, you need to identify and treat all of their partners. That baby is going to get erythromycin at birth. Erythromycin is ointment is standard of care unless the patient refuses it. This is a reportable infection to the Department of Health. The medication, when you are pregnant, we will treat you for both chlamydia and gonorrhea because they are often co-infections, especially in pregnancy. So in pregnancy, you're going to get IM ceftriaxone, which is the same thing as Rocephin, and then oral azithromycin. Your client education, you need to tell your patient to take all of her medications as prescribed. And when you are pregnant, we do a test of cure 3 to 4 weeks later. So if you're not pregnant, you tested positive, you get your treatment, we're done with you. But if you are pregnant, we're going to retest you in 3 to 4 weeks to make sure that the gonorrhea and or chlamydial infection is gone. You want to instruct your patient to adhere to safe sex practices, which is going to be condom use or mutual monogamy. And then complications of gonorrhea in pregnancy are premature rupture of membranes, premature birth. Whenever mom has an infectious process happening in her body, we have an increased risk of preterm birth. Postpartum sepsis and endometritis. You can have gonorrhea and or chlamydia. It can ascend into the uterus and infect mom's uterus. If it is ascended into her uterus, we can get chorioamnitis and neonatal sepsis. Gestational diabetes. We are going to be screening for gestational diabetes. We screen for it at the 28-week visit. The ideal blood glucose level during pregnancy is 60 to 99. And that's going to be before meals or fasting, and then less than 120, 2 hours after meals. Your patient is going to have very specific parameters of what their blood sugar should be, but those are kind of our general guidelines. Diabetes, it can appear following delivery, it disappears following delivery, and approximately 50% of the clients who are gestational diabetic will be type 2 diabetic later in life. So being gestational diabetic increases your risk of type 2 diabetes later in life. Your risks to the fetus. We can have a large baby. Macrosomia is a baby greater than 4,000 grams. They have issues with hypoglycemia after birth. You have increased risk of infection. Pregnant women with gestational diabetes are really prone to yeast infections. You can get excess amniotic fluid or polyhydramnios, ketoacidosis, hypoglycemia or hyperglycemia. Who is at risk for gestational diabetes? Our moms that have obesity, hypertension. If you are hypertensive, you are more likely to develop gestational diabetes. And the same is true if you are gestational diabetic, you're more likely to become hypertensive later in your pregnancy. If you have sugar in your urine, if you're over the age of 25, if you have a family history of diabetes, or previous delivery of an infant that was large or stillbirth. Shouldn't that be 35 years old?
Yeah, I was going to ask you that.
Yeah. The maternal age of over 35 years old, I believe that is an ATI in a sprint. So what is mom going to feel like if she is hypoglycemic?
headaches, weakness, nervousness, irritability, hunger, blurred vision, versus hyperglycemia. We've got increased urination, increased saliva production, nausea, abdominal pain, and that flush, dry skin with fruity breath. Physical assessment findings, you can see those there. The test that we do to see if you have gestational diabetes at 28 weeks, we're gonna do the glucola. So you don't have to fast for that one, the 1 hour test. You can eat that morning, that's fine. You'll go to the clinic, you're gonna drink your glucola, and an hour later, they're gonna test your blood. The oral glucose 1 hour screen is the 50-gram glucola. If your blood glucose screening is 130 to 140 or greater than that, that means that you did not pass your glucola screen and you need to go ahead and do the 3 hour test. The 3 hour test is fasting. You're going to go in, you're going to drink your glucola, and we're going to test your blood sugar at 1 hour, 2 hours, and 3 hours. You can't eat or drink anything in those 3 hours. The biggest thing with gestational diabetes is that we need them to maintain their optimal glucose levels. If they don't, they're going to be put on insulin. Your client education is going to include daily KIT counts, adhere to the appropriate diet. Usually this is going to be your standard counting carbs diabetic diet. They need to exercise. You would teach them how to use insulin if they need it. And then they do need a glucose test at their postpartum visit. Hypertensive disorders of pregnancy. We have got chronic hypertension, which is your hypertensive prior to pregnancy up until the first 20 weeks. We have gestational hypertension, which is blood pressure of 140 over 90. It's always on 2 occasions separated by 4 hours. You have no organ involvement, so you have no other symptoms. Preeclampsia is after 20 weeks, again, 140s over 90s, but now you have organ involvement. So if your kidneys are involved, you're going to have swelling and you're going to have protein in your urine. If you have liver involvement, you're going to have epigastric pain and elevated liver enzymes. If you have neurodevelopment or neuroinvolvement, you have headache, visual changes, hyperreflexia, and clonus. We're worried that if you are preeclamptic, that you could have a seizure, and that would be eclampsia. Once you seize, it's eclampsia. Preeclampsia with severe features is blood pressures of 160 over 110. If you are preeclamptic at any point, you can have a seizure and be eclamptic. We are worried that you're going to go into HELLP syndrome. What is HELLP syndrome? HELLP syndrome is hemolysis, elevated liver enzymes, and low platelets. So
Think of the video.
The liver produces a hormone called thrombopoietin that tells the bone marrow to produce red blood cells and platelets. So if your liver is failing because of your preeclampsia, you're going to have a decrease in your hemoglobin, which is hemolysis, and then you're going to have low platelets because you're not producing that hormone that stimulates the bone marrow to give you platelets. Risk factors, either you're an adolescent pregnancy or you're over the age of 40, first pregnancy, obesity, multiple gestation, if you already have kidney disease or hypertension, family history, diabetes, rheumatoid arthritis, and lupus.
You're a visual person.
Here's basically what I just said about the chronic hypertension, the difference between gestational preeclampsia with severe features. And then if you are chronically hypertensive, you are at risk for chronic hypertension with superimposed preeclampsia. So the diagnostic criteria and how they differ is this slide. This is a really good slide to study from.
Magnesium sulfate is a medication that we use when patients are preeclamptic because it prevents seizures. It does not treat blood pressure. It prevents mom from having a seizure. If you're going to give your patient mag sulfate, you need to tell them what to expect, how they're going to feel on it. Mag sulfate makes you feel like you've been run over by a Mack truck. You feel nauseous, fatigued, foggy, you get flushed, you feel anxious, you want to vomit. It's terrible. You have chest tightness. Mom is going to specifically feel those symptoms the most during the loading dose. And then once we're on the maintenance dose, which is going to run in slower, she won't feel that symptomatic. She's still not going to feel real great. The biggest risk factor for magnesium sulfate is that it can cause respiratory depression and respiratory arrest. So this is literally a medication that we can give you that could stop you from breathing. So when we give magnesium sulfate, you're going to have to stay at the bedside for the first 30 minutes. And you're going to be checking her blood pressure, her heart and lung sounds, her reflexes and clonus every 15 minutes to start. If she starts to become areflexive, so she no longer has reflexes, if her respirations are less than 12, those are all signs that she's going to stop breathing soon. What is your reversal agent? Calcium gluconate.
Good job.
Yep, calcium gluconate is the antidote for magnesium toxicity.
Like you hit.
I think I've hit all that.
Yep.
Yep. Preterm labor, this is between 20 weeks and 36 weeks and 6 days. So somebody who is in preterm labor, what we're going to do is if they come in because they're having contractions, they're having pelvic pain, whatever their symptoms are, they're going to come into the hospital or the clinic. We're going to do a fetal fibronectin. This is a vaginal swab that can be done between 24 weeks and 34 weeks and 6 days. When a mom is going to go into labor within 2 weeks, the fetus starts to elicit a protein. It's this alpha fetal fibronectin protein. So if we swab her and her fetal fibronectin is positive, she has an increased risk of delivering in 2 weeks. You would test for any other signs of infection. So you would swab for yeast, BV, any STIs. We might do an ultrasound to look at the cervical length to make sure her cervix isn't shortening. And then we're going to do a biophysical profile and a non-stress test to make sure baby's doing okay. Our goal for preterm labor is to delay delivery long enough for baby to get, or for mom to get 2 doses of betamethasone, which is the steroid injection to increase lung production of surfactant. It helps with lung maturity. We can use terbutaline. It's a sub-Q injection that is going to stop contractions. This is a high-risk medication, so we don't use it very often. You need to tell your patients that when you give it to them, they are going to feel their heart rate go up. It's very common that they're going to have a heart rate of 120 to 150. That's going to make them feel hot, flushed, sweaty, nervous, anxious. We're going to give them mag sulfate because it's a muscle relaxant. It's going to help calm the uterus. She's not going to contract as much. And it provides neuroprotection for a preterm baby. Preterm babies have very weak blood vessels, especially in their brain, and they're at risk for brain bleeds. Giving mom magnesium sulfate helps decrease that risk. Betamethasone is the steroid injection. She's going to get 1 dose and then she'll get the second dose 24 hours later. If she's going to deliver prior to 24 hours, we can do a rescue dose at 12 hours. It's better than nothing, but it's not quite as effective as 24 hours later. We still good, or do we need another break?
Let's go for another 15 minutes and then we'll take a break in 15 minutes because it's 9:44. So we haven't been lecturing for a full hour yet.
Oh, so another 15. Okay.
Yep.
Gotcha. Okay. So labors. We have 3 stages of labor. Stage 1 is being in labor. Stage 2 is having a baby. Stage 3 is having a placenta.
Stage 1 is further divided into latent, active, and transition. Latent labor is 0 to 4 centimeters. Active labor is 4 to 8 centimeters. Transition is 8 to 12.
8 to 10.
8 to 10. I'm so sorry.
I was like, interesting. 12
8 to 10
centimeters. All right.
centimeters. My brain is fried, guys. I can only.
I know, it's a lot. It's a lot. Second stage and third stage, should you hit?
Yep.
Okay.
Second stage is having your baby. The third stage is having a placenta. The fourth stage is just that postpartum period.
Yep.
After delivery.
Fourth stage is postpartum. Kind of your, I always say, rule of thumb, think 6 weeks with that for a lot of your answers.
Yes. So if you think that your water has broke, we can use nitrazine paper to test it. Nitrazine paper is pH paper. If it's amniotic fluid, it's going to turn from yellow to blue. Typically, labor is going to start within 24 hours of rupture of membranes. Prolonged rupture of membranes is if your bag has broke and you're not laboring within that 24 hours. And then immediately following rupture of membranes, whether mom's at the hospital laboring and her water breaks on its own, or if your provider is going to break it, you need to put her on the monitor to make sure we don't see any changes like decelerations. And this just kind of goes through ways that you can assess it, which is basically the pH paper. Leopold's. Before we had ultrasound to tell us which position the baby was in, we had our hands. So when you do Leopold's, these are 4 different hand placements that you're going to do on mom's abdomen to feel, is the baby head down? Is the baby breech? Is the baby transverse? Part of the reason that we do Leopold's, not only just to know if our baby is, head down, breech, or vertex, is because we are going to hear the heart rate the loudest with the fetal monitor if we place it over the fetal back. So if I do Leopold's and I can feel baby is head down and the back is on this side and the hands and feet are on this side, I'm going to put the fetal monitor here. If the baby's breech and the back is over here and the hands and the feet are over here, I would put the fetal monitor up here. So here's the fetal back. There's where I want to put the monitor versus in this breech position. Do you see how it's much higher? So I want to place the fetal monitor over the fetal back. Intermittent auscultation versus continuous fetal monitoring. If mom is low risk, she doesn't have an epidural, she doesn't have Pitocin running, she comes in, you put her on the monitor and she has a reactive NST, she can be intermittently monitored, which we can do with the fetal Doppler. That's the handheld way we listen to the baby's heart rate. When she's in latent labor, so she's less than 4 centimeters, we're going to listen every 30 to 60 minutes. You're going to put the monitor on. You're going to hold it there before a contraction, during a contraction, and then for the minute after the contraction, because we want to see if you heard any decelerations with or after the contraction. When she's in active labor, you're going to do it every 15 to 30 minutes. And then when she's pushing, it's going to be every 5 to 15. Continuous fetal monitoring is when you have that either external or internal monitor on, and we are listening to the fetal heart rate continuously and seeing the contractions. This is going to be needed for twins, if they're on Pitocin, if they have any sort of risk factors in the pregnancy or anything abnormal during their labor process. We'd want to put them on continuous monitoring. Do you guys feel okay with the fetal heart monitoring, like knowing what the normal fetal heart rate is and the veal chop and all that? Okay, cool. If you don't, and you don't have Brittany or I for your OB-SYN class, and you want a copy of our fetal monitoring PowerPoint, just email onto this and we can send it.
All of you should have access to that, because
Okay.
I know most of you were in my class, and then Patty did get a
She did
copy
it.
from
Okay, cool.
us to add to her class too. So
So when we're looking at pain management this is a good chart to study, but basically we have an epidural, we have IV, things like fentanyl, Statal, Demerol, all those sorts of things. We have nitrous oxide, and then we've got our non-pharmacologic pain medications. You need to know that when you have an epidural, one of the side effects is the epidural relaxes you so much, it relaxes your blood vessels, which causes you to have hypotension. So in order to counteract that, we're gonna give mom a liter of IV fluid prior to epidural placement, and we're gonna watch her blood pressure very closely after placement. With any of our IV medications, any of our IV narcotics, you want there to be an hour from administration till birth because we want to decrease the risk of respiratory depression in the baby. And if baby was born and had respiratory depression, you would administer Narcan. This just shows you what an epidural looks like and then those adverse effects that include the hypotension. This is just going to go through some more specific information, how frequently you're going to check their vitals. They're not going to be able to get up and out of bed to use the bathroom, so you're going to have to put a catheter in them. Induction of labor. So we need you to go into labor, whether it's because you have a complication in your pregnancy that you need to deliver, maybe you're hypertensive, you're diabetic and your blood sugars are out of whack, or you're like 42 weeks pregnant. What are some of the ways we're going to induce you? Let's go to the next slide. Okay, so their induction means we are starting your labor, you're not in labor at all. Augmentation means you're in labor, but you're not progressing fast. So we're going to do something to help things speed up. That could be breaking your bag of water. It could be starting Pitocin. When we're looking at amniotomy, this is when we break your water. Again, remember you have to put her on the monitor because we're worried that if we broke the water, we could have a cord prolapse. You'd see decelerations on the monitor. This is what a cord prolapse looks like. What do you guys do in a cord prolapse?
It's the number one thing. We talked about it.
Finders keepers. You take those fingers, you push that baby off of the cord, and you get a fancy long ride to the OR, and you keep pushing that up until the baby is out by C-section.
If we have exposed cord, what are we going to do with it?
Cover it with a sterile gauze. Saline.
Sterile gauze, okay? Gauze with the
Those
sterile
kind.
saline to keep it moist.
Yeah.
Yep. Charity,
Yeah.
you were on the right track there. Good.
Thank you.
This just kind of shows how we would do the elevation. You can put mom in this knee chest position that can help bring the baby up. RH negative moms and RH positive babies. So at 28 weeks, if mom is RH negative, she's gonna get Rogaine. Because we don't know whether or not that baby inside has RH positive or RH negative blood. But when you're in the third trimester, your rate of risk for maternal fetal blood exposure increases because you could go into preterm labor in the third trimester, right? So we do that prophylactically at 28 weeks. At any time in the pregnancy, if mom has something that could expose maternal and fetal blood, she has an amniocentesis, she has abdominal trauma, anything like that, we would give Rogaine again. After baby's born, we're going to draw cord blood. If baby is positive, mom needs Rogaine within 72 hours of birth, because if she doesn't, she's going to develop antibodies, which will then attack every pregnancy she has going forward. It will cause RH isoimmunization fetal hydrops, which is what this baby has going on, and these babies do not live.
It's really sad. Oh, let's, she's like, I'm done. Okay, since we are switching gears and we're going to be talking postpartum, let's do another 5-minute break. So we'll return at 10. So I guess that's 6 minutes, but 10 o'clock we'll leave off or pick up where we're leaving off now. one.
Have you guys taken those?
The dynamic.
The question bank on ATI?
Okay.
Yep,
Yeah.
there's 400 maternal ones.
Yeah.
Make sure you've done them all.
Yeah,
It makes a huge difference.
it's a lot, I know, but I would say, oh, go for it. You still didn't do, yeah,
No, me
weren't
too.
as successful as you were hoping to be probably on the ATI. I know it's a lot. So hopefully with us going over this, we're just like keeping our fingers crossed that we'll hit literally every topic that you could come across.
And
And
we actually pulled up the maternal ATI book and like took it word from word
Yep.
from the ATI book to try to make, because we can't see the questions. We
Mm-mm.
see the outlines, the topic outlines. So like when it talked about emergency contraception, I literally took it straight out of the book because you would think that their questions would be based on.
Their textbook.
Right.
So that's why we kind of kept this up. All of this content is being pulled from your ATI. So
Students read the ATI book, like, do they know that it exists and how to access
you
it?
can, we're not gonna like hold it against you. We're just
it's- we're not
curious.
muted right now.
Oh, no, we're not.
Oh, sorry. They can't see.
But I know that's not something that when you have an e-textbook that you commonly look at. And for future classes, I'm telling you, you have to look at your textbook, guys.
Especially your ATI textbook if you're taking an ATI test, because
Yeah.
you guys know just as well as we know that ATI is its own little like island. And we're not super big fans of ATI,
Yeah.
but it's the reality of what the school uses. So if you're studying for an ATI test, you need to study from that
ATI
book.
textbook.
Yeah.
Okay. And that's what we're doing today.
Yeah.
So let's get started with postpartum. I don't know again if we're going to be able to get through all of the content before you guys have to take off, but we will do our best to try to get through as much as we can. So postpartum assessment, keep in mind, this should look familiar because this is something that we covered in our sim classes. We're going to want to do vital signs every 15 minutes for those first 2 hours after birth. Then it's going to be every 30 minutes. Then it's going to drop to every 60, and then every 8 hours thereafter, or by your hospital policy. Okay, so that's where hospital is going to decide how often they're wanting you to do those assessments and vitals. Temperature, according to ATI, you're only needing to do every 4 hours, and then times 2, and then every 8 hours thereafter. So just keep that in mind for your ATI. Now, your focused physical assessment. For your ATI, they only have the bubble format there, okay? And we talked a lot about like bubble HE, even in our sims. So the ones that they wanted you to focus on are your breasts, uterus, bowel function, bladder function, lochia, and the episiotomy. Keep in mind, we're not going to have, every single patient is not going to have an episiotomy. At least I hope they don't, okay? So, but they will likely have some tearing. So when you think of the E, I need you guys to think about the tear, okay? So when we think about the tear, what are some things that we're wanting to assess with that? Yeah, I heard a whisper of infection. So what would be some signs and symptoms of infection? Fever? Could be. What are some visual things that you might see?
Right.
Yep. Redness, swelling, maybe discoloration, maybe some drainage, could have some odor. Now, keep in mind, right after delivery, is she going to have swelling? She is. So we got to kind of like use that thought process, okay? So with your bubble, you're also going to be doing those vitals and your pain assessment, teaching needs, depending on the client, right? And then we're going to want to try to encourage her, you guys, ask her, did she go to the bathroom? Did she void recently before we jump into our assessment? Why? Why do we want to make sure she has an empty bladder? The fundus, right? And how that fundus feels, okay? So that's something that we need to think about. Real quick, Lindsay, I'll have you go right back.
Oh,
just for a
yep,
second.
sorry.
No, you're fine. The ones in red are your priority assessments, okay? And we should, hopefully that stuck with you after sim. So if we're dealing with a patient that just had a delivery, okay, she just delivered, you're going to be thinking about checking that uterus, the lochia, her vitals, okay? Those are going to be the pertinent assessments that you're going to want to complete. Ways to help with contractions. Oxytocin, that's going to kind of be our first line medication for that postpartum hemorrhage. Remember that we can give that IV or IM, okay? Your methergin, keep in mind with your methergin, you guys, hypertension is that contraindication. So we're only going to give that IM, okay? Never through the IV. Hemobate, we also give that IM. The side effects with this one, rough, okay? So we do want to make sure that we're giving some PRNs to help with that nausea, the vomiting, and the diarrhea that they're going to experience if we have to give that Hemobate. Cytotec, that one can be given PO or rectally. We do want to make sure that we're encouraging them to breastfeed. Why? What is that going to help with? Their oxytocin, that oxytocin release is going to help with those contractions, okay? Again, make sure that they're emptying their bladder and that they're going to the bathroom regularly, because if they're not, we're going to feel that on our fundus assessment, because is it going to be midline if she has a full bladder? No, it's not, okay? Lochia, let's talk about that a little bit. So remember the stages of that lochia. It's going to first be kind of like a heavy period, okay? And that's going to be that rubra, so that darker, brighter red colors. And then that's going to last roughly first few days, okay? Up to that 4th day usually. And then it's going to transition to that serosa. So that's going to be more of that pinkish color, okay? As it's transitioning down through these different stages of that lochia, you should have less and less bleeding, okay? So that's also why we're seeing some of these color changes as well. That serosa, roughly days 4 to 10. And then that alba can be up to 8 weeks postpartum according to your ATI, okay? So that is more of that creamy color, okay? So this can have, like, I almost say like, almost like a yellowish tone to it, you guys. So it's not always just like white. So I don't like when your textbook, I know for lecture, says white. Keep in mind it can have almost like a yellowish hue to it too. Outside of that, yes, just keep in mind that that heavy menstrual period is going to be for roughly about 2 hours after that delivery, and then it should gradually start to decrease after that, okay? All right, a nurse is performing a fundal assessment for a client who is 2 days postpartum and observes the perineal pad for lochia. The pad is saturated approximately 12 centimeters with lochia that is bright red and contains small clots. Which of the following findings should the nurse document? Moderate, excessive, light, or scant? So did we have that on the previous slide of the measurements that we did somewhere?
Nope, I think it's
It's
in the
not.
it's in the lecture.
Okay, in the lecture ones. So that has us going back to thinking about how much coverage of that pad is being saturated and if that seems normal or abnormal, okay? What do you guys think if you had to guess? Probably moderate. Okay, so we're gonna go with A. That go over here. Okay. All right. During ambulation to the bathroom, a postpartum client experiences a gush of dark red blood that soon stops. On assessment, a nurse finds the uterus to be firm, midline, and at the level of the umbilicus. Which of the following findings should the nurse interpret this data as being? A, evidence of a possible vaginal hematoma. B, indication of a cervical or perineal laceration. C, a normal postural discharge of lochia. Or D, abnormally excessive lochia rubra flow. What do you think? guys are thinking C?
Yep, that's what I'm getting on here too.
All right. So you guys are, I don't think I did like answer slides on those ones today.
Okay.
I
no.
think they are just like within.
It's on the or on the PowerPoint versus the.
Yep. So with your guys' PowerPoints, if you do want to go back and look at the answers, I did put those within the notes section, just for those that also are online and want to know.
So for the first one, it would be excessive because of the clots, right? And the 12
No,
inches.
because of the small clots.
Oh, gotcha.
It's actually going to be the moderate.
Gotcha.
And then for 2, because remember, small clots, is that normal initially to have some smaller clots? Yeah, it is. But what are the abnormal clots? What size? Golf ball?
Yes.
Or egg sized, okay? Those are the things that I want you to think about. So technically, if she's having some small clots, then that's fine, okay? So that's why that one would be that moderate. And then for number 2, you guys are right. It is expected because if she's been laying down for a while, what's probably happening? What do you think? If she hasn't transitioned or repositioned herself in bed, is it likely that she might have a little bit of pooling of blood in her vagina?
Mhm.
Okay, so then when she gets up, is that going to cause a little bit more of that bleeding because of her change in position? Does that make sense? Okay, so that's why those ones are correct. So you guys did good with that. A nurse is providing education to a client who is 2 hours postpartum and has a perineal laceration. Which of the following information should the nurse include? Select all that apply. A, use a perineal squeeze bottle to cleanse the perineum. B, sit on the perineum while resting in bed. C, apply a topical anesthetic, cream, or spray to the perineum. D, wipe the perineum thoroughly with a back and forth motion. And E, sorry, I forgot what letter I was on. Apply cold or ice packs to the perineum. What do you guys think?
Got A and D.
A and D, did I?
Yep. So use the perineal squeeze bottle. Wipe the perineum thoroughly back and forth.
Okay. You're thinking E? Okay.
A, C, and D. So we're gonna have to talk about D because we've got a bunch of those.
Okay, we'll talk about that. So let's just hit that one right away, okay? Are we gonna tell her to use a perineal squeeze bottle? Yes, we are.
Yeah.
Why? Why do we want her to use the peri bottle? We don't want her wiping. So that kind of eliminates D then. Why don't we want her wiping, you guys? Is that going to irritate that site even more, especially if we place sutures? Yeah, it is. Okay. So we only want her to use the peri bottle. And if she feels like she needs to pat dry, that's fine, but we want her to be really gentle with it. We don't want her to be wiping back and forth like that. Okay. Because that's going to irritate it further. All right. Do we want her sitting directly on the perineum? What do you think? Probably not, right? Okay. What about the topical anesthetic cream or spray? Actually, we have those available in the hospital. It's called a dermaplast spray. And it looks almost like a little like spray can, like a hairspray bottle.
Yep.
Okay. And then they can spray that kind of back and forth to help numb that area to decrease some of the discomfort that's associated with it. Okay. And then can she use colder ice packs to her perineum to help with swelling? Absolutely. Okay. So technically the correct answers then are what? A, C, and E.
Yep.
Okay. All right, let's do the next one. A nurse is assessing a postpartum client for fundal height, location, and consistency. Fundus is noted to be displaced laterally to the right, and there is uterine atony. The nurse should identify which of the following conditions as the cause of the uterine atony: or involution, urinary retention, hemorrhage, or infection. B, do we all agree on that?
Yep.
Yes. because we just talked about how if we have a full bladder, is that fundus going to be midline? Nope. Okay. So then we know that there's possibly something going on with the full bladder. On the PowerPoint that I gave you,
It's in the notes.
it's in the
at the
note
bottom.
section. The answers are, okay?
You just
So-
don't see it in presentation view.
Yeah. Because those ones I pulled from like your ATI textbook as I was going through it. So it didn't have like the answer breakdown, but it will have the answers in the notes section on the PowerPoint I sent to all of the students, okay? All right, let's talk a little bit about hemorrhage, okay? So 500 mils of blood loss or more with a vaginal delivery, then we're thinking hemorrhage, okay? However, with a C-section, it's 1,000 milliliters or more. Then we have talked about this, and I told you guys about the 4 T's, okay? That brings us back, for those of you that have done SIM, something that we wanted to remember, okay? Those 4 T's are tone, trauma, tissue, and thrombin. So if you can think about those 4 categories, it'll be really helpful to think about all the different things that could cause that. So for tone, you guys, that's going to be like your uterine atony. That uterus is not contracting effectively. So if we have an overdistended uterus, it's going to have to work that much harder to get back to that pre-pregnant size. So think about the things that could overdistend a uterus: bigger babies, more than one, polyhydramnios, lots of those things. Prolonged labor, is that going to cause the uterus to get really tired out? It is, okay? So then it's not going to contract effectively because it's going to be like, oh, I'm so exhausted. I'm done. I don't want to contract anymore, okay? Oxytocin-induced labors, again, that oxytocin is like, contract, 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 contract. So then postpartum, that uterus again is going to be like, man, oh man, I can't do this anymore. You're kicking my butt. Because we had that oxytocin going, it's going to cause that uterine fatigue. High parity, the more pregnancies we have, the more that uterus gets stretched out, the harder it has to work to get back down to that pre-pregnant size. Magnesium sulfate, what is that? What does it do to our muscles? Relaxes them. So is our uterus going to be in the mood to contract when it's really nice and relaxed? Nope. Okay. And then anesthesia. Okay, because that's also going to impact the ability of that uterus to contract effectively. Trauma, I want you to think about those vaginal lacerations, precipitous birth. When we have those really fast births, there can be injury or trauma associated with that. Hematomas, uterus or ruptured uterus, and then inversion of the uterus too. So that is all associated with trauma. Tissue is going to be those retained placental fragments. Thrombin, Lindsay kind of hit on this a little bit when we were talking before. Think about those different blood disorders, okay, that could cause excessive bleeding. DIC, which is the result from certain things like preeclampsia or placental abruption. So those conditions can cause issues with thrombin. So when we do have uterine atony, okay, the things that we're going to need to do is first feel that fundus to see how it feels. Okay, if we have uterine atony, is it going to feel boggy or firm? With uterine atony, it's going to feel boggy, okay, because that's what's going to cue us like, oh, we should be engaging in massage right now. So that's what we're going to want to do. Remember to protect the uterus by having that lower hand in place when you guys engage in that fundal massage. We're going to definitely want to make sure that we're monitoring those vitals, okay? Because we want to keep track of what is happening with those vitals. Are we seeing improvement in those vitals, or is she continuing to decompensate, okay? Assess that bleeding. And then we need to figure out where that bleeding is coming from. Is it just from the uterus, or are there other things that could be contributing to that blood loss? Make sure that we assess that bladder, okay? How did that fundus feel? Was it midline or not? If it wasn't, and we're thinking she has a full bladder, we're going to have to straight catheter to empty it, because that uterus is not going to contract effectively if we don't empty that bladder. Maintain or initiate IV fluids to kind of keep that blood pressure up.
maybe consider some oxygen, okay? And then consider elevating the client's legs to help kind of get that blood flow to those essential organs. So then thinking about kind of that Trendelenburg position. Yeah. Trauma, hematomas, that is when we have that collection of blood within the tissues. So that's going to appear as almost like a bulging bluish mass sometimes, you guys. Think back to our lecture, and Lindsay had put some really good pictures of that on the slides, which I know was kind of in your face, but also really good to be able to visualize what that might look like. It can occur in the pelvic region, high in the vagina, or a broad ligament. Pain, rather than noticeable bleeding, is going to be a distinguishable clinical finding of hematomas. For some reason, that is something that I feel like you guys should know. Okay.
It's like sudden onset of pain, because when it happens so quickly. You can have like 2 liters of blood inside a hematoma in seconds. And it's so
It's
painful.
rapid. Okay. They are at risk for hemorrhage or infection. Some expected findings, again, is going to be pain and pressure sensation in either the rectum or the vagina, and they're going to have some difficulty voiding with that. On physical assessment, again, you're going to find a bulging bluish mass or area of kind of like a red-purple discoloration on the vulva, perineum, or rectum. Nursing care, we're going to inspect the vulva, perineum, and rectum for those hematomas. Again, assess those vital signs. Ice packs for small hematomas. We're going to administer pain meds, encourage sitz baths, and frequent perineal hygiene. Okay. And then we might need to do an incision and drainage for those larger ones to remove any of that clotted blood in there. Okay. So we talked about different things that can impact our coagulation. So that's going to be things like your ITP, which is an autoimmune disorder. Okay. And then you have your DIC that we listed there. So I'm not going to go extensively into this because the definitions are laid out for you there, but those things are going to be suspected when usual measures to stimulate that uterine contractions fail to stop that bleeding. Okay. So if we have oozing, trickling, flow of blood from incision, lacerations, or episiotomy, that's when we need to think that we kind of have some coagulation issues going on. If we have some blood in our urine, any gastrointestinal bleeding, tachycardia, hypotension, diaphoresis. Again, your lab findings, we kind of already talked about this too, so I'll just briefly hit those. We're going to maybe have some thrombocytopenia, fibrinogen levels are going to be decreased, PT might be prolonged, fibrin split product levels are going to be increased, and your D-dimer test is going to be increased as well. So the main thing with this is we need to figure out what that underlying cause is, and that is what we need to correct. We're going to think about fluid replacement, antibiotics, vasoactive meds, your uterotonic and medications, okay? And then also supplemental oxygen. Okay, a nurse educator on the postpartum unit is reviewing risk factors for postpartum hemorrhage with a group of nurses. Which of the following factors should the nurse include in the teaching? Select all that apply. What do you guys think? Precipitous delivery, obesity, inversion of the uterus, oligohydramnios, retained placental fragments. You're thinking C and D? Anyone else? So we got inversion of the uterus and A, B, C. Oh, D, did you want oligohydramnios or E, retained placental fragments?
Oh, maybe.
Yeah, I was just checking. I thought maybe you did, but. Okay, anything else? Okay, precipitous birth. What does that mean? Really quick delivery, right? Happened really fast. So with that, is there possible trauma that could be associated with that or injury? So could that lead to increased chances of bleeding? Okay, so should we include that one maybe in our answer? All right. Inversion of the uterus. Good job. Because if we accidentally invert that uterus, is it going to cause some excessive bleeding? Is that a traumatic situation that might be happening? Yeah, okay.
I've seen one inverted uterus and she died.
It's really bad. It's terrible. I'm glad I've never observed that.
Yes.
That's just so horrible.
Cool.
Oligohydramnios. Now, what's the opposite of this one that could cause stretching out of the uterus? When we have excess fluid, what is that one called? Polyhydramnios, okay? So if it was poly, maybe that could be a culprit, but oligo, not really, because that's the opposite. Retained placental fragments, is that going to cause bleeding? Sure will, okay? Good, so the answers are A, C, and E for that one, okay? A nurse is caring for a client who is postpartum. The nurse should identify which of the following findings as an early indicator of hypovolemia caused by hemorrhage. A, increasing pulse and decreasing blood pressure. B, dizziness and increasing respiratory rate. C, cool, clammy, and pale mucous membranes. Or D, altered mental status and level of consciousness. What do you guys think? Early indicator.
I'm just gonna say, what is your clue phrase in there?
So that's where you have to really pay attention to be like, what is this question really asking me? I'm popping through online there.
Not quite yet for this one.
Okay. What's your guess? C? You're thinking C? Okay, we got one guess of C. Any online?
C.
Not yet.
Do I have them written out on all of them? Good. Okay, I wasn't sure, but
Any other guesses? Hey, Lindsay kind of hit this when we were talking about the body changes a little bit, okay? So initially, you guys, is our body going to try to compensate for that blood loss? It is. So the way that our body is going to try to compensate for that blood loss is with an increased pulse as that blood pressure is decreasing, okay? Because it's like, okay, I'm going to have to try to like pump a little bit harder to see if I can get this blood really flowing through the body. Does that make sense? So the correct answer for that is actually going to be A. All right, move on. Another question. A nurse is caring for a client who has disseminated intravascular coagulation. Which of the following antepartum complications should the nurse understand is a risk factor for this condition? DIC. What were the conditions that I said could lead to DIC? Preeclampsia. Everyone agree with that? Yeah,
Yep.
correct. Good job. All right, so we're going to talk a little bit about breasts, okay? And when that milk comes in, remember that's going to be roughly that like 3 to 5 day interval when that milk comes in. And when that milk does come in, she's going to be experiencing engorgement, okay? So what are some things that will tell her that she's experiencing engorgement? Going to appear tight, tender, warm. They're going to feel really full. Honestly, feels like you have like rocks on your chest. Okay, it's really, really uncomfortable. So if she's not breastfeeding, okay, she's choosing not to breastfeed, these are the things that we would tell her to help decrease that milk supply. Is that eventually it will resolve on its own, but we want to make sure that we are using like really tight or constrictive bras, like really supportive bras, okay? She could even bind her breasts. And then ice pack and cabbage leaves can be applied because that will also help decrease that milk supply, okay?
Well, so you put them in the fridge or the freezer so that they're cool, so the coolness helps decrease inflammation. But there's actually part of like properties that make up cabbage leaves have an anti-inflammatory
Now,
process
they-
to it.
Something to where it's like,
They work, like crazy work. Yeah.
yeah, it's really interesting, some of the things that we come across, and who knows how we came across that. It's so weird. Like, I would be interested in that story. Breastfeeding. Now she's breastfeeding, so obviously we don't want to impact that milk supply. Okay. These are the things that we can tell her to do. Breast care and frequent feedings is going to help prevent future engorgement episodes. Warm showers or warm compresses before breastfeeding. Okay. So like right before, because what that's going to do is help prevent or promote, excuse me, that letdown reflex, which is going to allow the breast to secrete all of that milk that's stored in the breast. Empty breast completely with feeding. So if baby is full and she feels like her breasts still have some milk in them, then we're going to encourage her to use the pump afterwards. Okay. But we always want to make sure to offer the feedings to the baby first before we pump. May apply cool compresses after feedings, not before. Okay. So again, lactation suppression, well-fitting supportive bra for first 72 hours. Avoid any breast stimulation or warm water running over the breast. Okay, because like we said, that's going to help for those that want to breastfeed, but for those that don't, then that's not something they're going to want to do. Okay. And for breast engorgement, again, apply those cold compresses, 15 minutes on, 40 off, 45 off. Again, those cold cabbage leaves can be placed inside the bra. And then you can use some medications, you guys, like Tylenol and ibuprofen to help combat that pain too. Question?
No, it's
Okay.
the simulation meeting.
Thrombophlebitis. So this refers to thrombus that is associated with inflammation. It's going to most often occur in those lower extremities there. So it can be superficial or deep veins. Postpartum, we're at greatest risk for those DVTs. And then that can lead, as Lindsay was talking about before, to those PEs. Okay. So then we need to think about not only the signs and symptoms that we would experience with a DVT, but also if it travels and causes a PE, what are some of those signs and symptoms that we would see with that too? Risk factors for this is pregnancy, cesarean birth, operative vaginal birth, immobility. That's why we want to get people up and moving. Obesity, smoking, multiparity, and advanced maternal age. Management, bed rest and elevation of the extremity above the level of the heart. Change positions frequently, okay? Administer intermittent or continuous warm, moist compresses. We do not want to massage the affected limb, okay? Because we don't want to dislodge that clot. Provide anti-embolism stockings for those high-risk patients. We're going to administer some NSAIDs and some anticoagulants for those patients. Endometritis. So this is an infection of that uterine lining or endometrium. And so this is usually begins that 3rd or 4th day postpartum, and it's going to start as a localized infection, okay, right where that placenta was attached. And then it's going to spread to include that uterine endometrium. Causes for this, prolonged rupture of membranes. So that's again why it's really important to identify how long her membranes have been ruptured for. Kind of the question that we say we always like to ask women when they come in if their water bag did break. If she had retained placental fragments or manual extraction of that placenta, that puts her at risk for something like this. Chorioamnionitis, multiple vaginal exams after rupture of membranes. Hence why I say we always want to minimize even when we're using those sterile gloves, okay? And then prolonged labor. So some signs and symptoms, you guys, that we're going to see with that is going to be pelvic pain, chills, fatigue. Some exam findings is going to be that uterine tenderness and enlargement. So think about where we would expect to find that uterus postpartum. It's likely that she's going to be measuring larger than what we would expect, okay? Dark profuse lochia, temperatures it's supposed to say greater, sorry, than 38 degrees Celsius or 100.4, and then some tachycardia. Treatment is going to be clindamycin or some cephalosporins. You might see some penicillins for this or gentamicin. Okay. Infections, mastitis. So I heard this was a big topic on your exam. So know the things for mastitis, blood ducts, all of those things. Okay. Now mastitis is going to be that breast infection that we can see. And the thing with this is if it goes, like if we go without treating it, it can actually progress to an abscess. Okay, so we do want to make sure women are aware of the signs and symptoms that are associated with that so they can come in and be evaluated and see if we need to put them on an antibiotic. Causes is milk stasis caused by those plugged ducts. Engorgement or a bra with underwire we know can contribute to this as well. Nipple trauma, cracked or fissured nipples, which is why we're always assessing the breast to see if we see any of those signs when she's been breastfeeding. And then again, poor breastfeeding techniques with that improper latch. So that's why it's really important to make sure we assess that latch. Weaning with breastfeeding and poor hygiene with the breasts. So usually the Staph aureus is usually the infecting organism with this mastitis. Some signs and symptoms that she's going to experience is that painful, tender, localized hard mass. It's likely she's going to have a really red area on her breast. She is going to have flu-like symptoms with this, okay? So as you can see there, chills, fever, headache, body aches, fatigue, and then she will have some axillary adenopathy. Wow, I can't even pronounce that. Adenopathy, an affected side with that area of inflammation. So you can kind of feel those lymph nodes down there to see if she's swollen at all. Treatment is going to be antibiotics. I stole that picture from your ATI to just give you guys an idea of what it could possibly look like. Educate. So what are the things that we're going to do to educate her to avoid this happening? Well, make sure that she's feeding that baby properly. Make sure that it's a proper latch. Making sure she's emptying those breasts, okay? Ice warmth to the breast for discomfort is fine. Feeding frequently, even when she has the infection, we want her to feed off that side, okay? So important, because I feel like you guys get confused with that and you think she shouldn't be feeding on that side. She actually does want to continue to feed. Making sure she's resting, she's getting enough fluids, and she's taking some medications to help manage her pain and discomfort. And she has to complete that full course of antibiotics. Discharge teaching. So when the call, okay? Really important for her to be aware. Chills or fever greater than 100.4. Remember, anything above that 100.4, we're thinking what? Infection of some sort. Okay. Change in vaginal discharge. So we talked about that lochia pattern. If it's not following that pattern, she should let us know. Or she has all of a sudden an increase in bleeding again when she's at that cirrhosis stage. We want to know about that. Okay. If she has excessive clots, are we going to want to know about that? Yeah. If she has an odor, are we going to want to know about that? Absolutely. Now, if all of a sudden she had a tear that was repaired and there is, you know, a foul smelling drainage, maybe there's some swelling, maybe it's not well approximated. We're going to want to know those things, right? We want to make sure that we can check that out because it's likely that it's not healing properly. Any pain or tenderness in the abdominal or pelvic areas, okay, that doesn't resolve when she uses some of those over-the-counter meds like Tylenol and ibuprofen. Again, breasts with those localized areas of pain and tenderness, or if she has like cracked nipples or open areas to her nipples, we're going to want to know about that. Any pain, tenderness, redness, and swelling in the calves. Why? What is that indicating? Does that indicate, guys? Pain, redness, swelling in the calf.
DVT.
DVT. Yep. Urination with burning, pain, frequency, urgency, because that's telling us she's probably got a UTI. And then indications of possible depression, okay? So has she been having a hard time at home and expressing some of those or displaying some of those depressive symptoms that we have talked about prior in class? All right, some questions. A nurse is planning care for a client who is postpartum and has thrombophlebitis. Which of the following nursing interventions should the nurse include in the plan of care? Apply cold compresses to affected extremity, massage the affected extremity, allow the client to ambulate, or measure leg circumferences. What do you think?
Allow the client to ambulate.
We've got one for C.
Okay, got one C. Any other thoughts? Maybe A. Okay, any other thoughts? All right, Lindsay, what do we got for the answer?
D. Measure the leg circumference. That's going to be able to tell us, remember, the leg that has the larger circumference is the one with the DVT.
Sorry, guys, give me a second. I'm going to put in another cough drop because my throat is just a little sore. A nurse on the postpartum unit is assessing a client who is being admitted with a suspected DVT. Which of the following clinical findings should the nurse expect? Select all that apply. Okay, so calf tenderness to palpation, modeling of the affected extremity, elevated temperature, area of warmth, report of nausea. What do we think? Elevated temperature. Okay, so that's C. What else? Okay, area of warmth, which would be D. Making sure I know my letters here. There's none on there. A. Yeah, anything else? Ding, 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 ding. Really good job, you guys. All of those were correct. A nurse is conducting a home visit for a client who is 1 week postpartum and breastfeeding. The client reports breast engorgement. Which of the following recommendations should the nurse make? All right, apply cold compresses between feedings. Take a warm shower right after feedings. Apply breast milk to the nipples and allow them to air dry. Use the various infant positions for feeding. So the stem of the question, we got to figure out, okay, they're asking about breast engorgement. So what are these things that we would do for breast engorgement?
A.
A. Good job. Okay. A nurse is providing discharge instructions for a client. At 4 weeks postpartum, the client should contact the provider for which of the following client findings? Is it scant, non-odorous white vaginal discharge, uterine cramping during breastfeeding, sore nipples with cracks and fissures, or decreased response with sexual activity? Good job, you guys. Everything else is expected, okay? Oh, wow, I had a lot for this one. A nurse is providing discharge teaching for a non-lactating client. Which of the following instructions should the nurse include in that teaching? Wear a supportive bra continuously for the first 72 hours. Pump your breasts every 4 hours to relieve discomfort. Use breast shells throughout the day to decrease milk supply, or apply warm compresses until milk suppression occurs. What do you think? Good job. Okay. A nurse is providing discharge instructions to a postpartum client following a cesarean birth. The client reports leaking urine every time they sneeze or cough. Which of the following interventions should the nurse suggest? Sit-ups, pelvic tilt exercises, Kegel exercises, or abdominal crunches? We got one for B. Any other thoughts? Okay, what muscles are we wanting her to like use or strengthen?
So
For pelvic floor ones, right? Which ones would, and I know that kind of,
The
that's
pelvic
kind of-
tilt makes you, is trying to trick you,
yeah,
but that pelvic tilt is just rocking
yeah.
forward
like
and
this.
back.
So is that gonna be helping your pelvic floor muscles? No, it won't, okay? We actually call the exercises that enhance your pelvic floor muscles Kegel exercises. Like, how would you explain, like almost like you're holding your bladder because you have to go to the bathroom really bad, okay? And you're kind of like holding your bladder to try to not like pee yourself as you're trying to get to the bathroom. Do you have a better way? I guess?
Typically, like if you have already started to pee and the muscles you would use to stop the stream of
Yes.
urine.
Yeah, that's a better way. So if you're like trying to stop peeing midstream, think about the muscles that you would be using to stop that. That's a better way to put it. Yeah. So that one would be Kegel exercises, okay? All right. Newborn identification bands. I have heard this discussed, so I put it in here because a lot of people were like, when would you put this on? ATI says,
ATI really say footprints and thumbprints?
yes.
I've never seen that
I know.
ever.
That's why I put it on there. Like, okay, sounds good. So immediately after birth, you guys, the identification bands go on right away, okay? And then we want to make sure that we have the name, sex, date, time of birth, and client's health record number on that band. One of the bands is placed on the ankle, one on the wrist. And then according to ATI, newborns' footprints and clients' thumbprints are taken for that too.
Never seen that.
I've never seen that either, but that's what it says with that newborn identification when it's under that band section. So each time the newborn is given to the parents, identification bands should be verified against the client's identification band. So that way we know the right baby is going to the right parents. Newborn vitals. So these are just the breakdown of those newborn vitals. Really important just to have this memorized, guys. Okay, because you're going to get questions and you need to know if those vitals are normal. I hope you don't get too many of the blood pressure because honestly,
I don't think so, because you don't do it unless they're NICU.
I know. So I don't really feel like, hopefully you guys won't get too much on the blood pressure, just to be cautious, maybe remember it, okay? But more so it's gonna be that respiratory rate, the heart rate, temps, and oxygen, okay? And just know that 95% is like, or above is ideal for that oxygen, okay? Airway clearance. So usually you guys, those newborns can do pretty well as long as they're crying and coughing to clear out those airways, okay? You can do routine suctioning of the mouth and then the nasal passages with that bulb syringe if they have excess mucus, okay, and they're struggling. Newborns that are delivered via C-section, they are going to have a harder time because if you think about it, they're not going through that birth canal, which is also squeezing them. So that can also help expel some of that fluid out of their lungs. Whereas in the C-section, we're kind of just like cutting her open and grabbing the baby out. Okay, so if you think about that, obviously those babies then are probably going to struggle a little bit more, right? Does that make sense? Bulb syringe is kept with the newborn at all times. Make sure that we do educate the family on how to properly use that and make sure that they demonstrate the use of it to you at the hospital, okay? So that is one of those things that we talk about where it's really important to have that demonstration of understanding. So we want to make sure that they compress the bulb before insertion into one side of the mouth, avoid the center of mouth to prevent stimulating that gag reflex in the baby, and then aspirate the mouth first, one nostril, then the second one. I could easily see that being like a question of what to do first.
Mouth to nose. So remember that Rasmussen is in Minnesota, M beforehand, mouth to nose.
There you go. All right, newborn temperature. So remember, there are a lot of things that can cause that baby to lose or to dysregulate their temperature, I should say. Okay. So they don't have the greatest ability to regulate temperature properly, which is why we always tell you guys, like as soon as those babies are born, that's why we want those warm blankets ready. We want to put them skin to skin and we want to dry them off and stimulate them and get them under those warm blankets to avoid them losing heat. Okay, because that can cause further complications if those babies are getting cold. So this slide goes over the different heat loss mechanisms of convection, radiation, conduction, and evaporation. So just know the different ways that we can lose baby's heat. I'm not going to go over them since they're very well listed out there, but I have a feeling you'll get at least one question on that. Okay. Skin. So is it normal to have bluish coloring in the extremities? Yes, it is. Okay. What do we call that? Acrocyanosis. Okay. That is very normal with those newborn babies. So that isn't something that is like super alarming. It's a central cyanosis that we're concerned about, but acrocyanosis, that is expected. Okay. Also, some other things that you might see is if those babies have increased bilirubin levels, you guys, what is that going to cause their skin color to turn to? Okay, I saw you whisper it, kind of like a yellowish hue. Okay, good. And then I don't know if that was on there. Maybe it's lower into the other slides, but which way, how is that going to progress? Is it going to be like feet upwards or is it head downwards? Okay, starts up here and works its way down. Okay. Skin turgor, it should see that it's very quick. Otherwise, obviously, if it's not, that's going to signify to us that baby is not well hydrated. Texture should be dry, soft, smooth, showing good hydration. We can see some cracks in the feet and hands. That's normal. And then sometimes we'll see a peeling of that skin a couple days after birth too. So letting parents know that that can happen. That vernix is that kind of thick, cheesy kind of substance that the babies are covered in when they're born. So the degree of that, of how much there is dependent. Okay, it can vary. There is going to be more, however, in the folds and creases of that skin of the baby. So keep that in mind. And then lanugo, again, is going to vary depending on gestational age and other components. But that is kind of that hair, that fine hair that covers baby. Skin assessments further, some normal deviations that we might see. So some, I thought we had a picture, but maybe I didn't on that one. So sometimes you'll see, you guys, these really kind of white, tiny, almost look like really mini white pimple things on their nose, their chin, their forehead. It is in our newborn PowerPoint. That is normal. Okay, that is that milia that we can see for that covering. So just let parents know that we don't want to be squeezing those. Okay. Mongolian spots, the new term that we're using is gray spots, I believe. Haven't you heard that too?
I haven't.
Because of just
Mongolian is kind of offensive.
Yeah, it's offensive to just say Mongolian spots. So they're starting to call them gray spots now, just to steer away from that. So these are going to be kind of like what you see on the slide there in that middle picture, where you're going to have little areas of blue, gray, brownish, black. They are really common on the back and the buttocks, and those are going to be more likely in people that have darker skin, and it can be related to genetics. So oftentimes, if we do see those, we do want to document those, because why? Why do you think we want to document those? What is the concern? What do those look like? They look like bruises, right? So we're going to want to make sure that we document those appropriately and also notify the parents to tell them like, hey, these are just kind of like a normal deviation, but keeping track of that so that way we can interpret, okay, was this spot noted within the chart, or is this something new too that they can compare to? Another thing that you'll see is in that top picture right there, we call that a stork bite. I'm not even gonna.
I was just gonna say, I want to hear you try to say that.
Laryngeecectic nevi. That's what
Okay.
I'm
I think that sounded good.
that is kind of a flat pink red mark, easily blanches. They're oftentimes found on the back of the neck, the nose, the upper eyelids, and the middle of the forehead there, like you can see on that little cute baby. They do tend to fade by that second year of life. So as you can see, they do stick around for quite a while, just letting parents know that that can be normal. Nevus lamius, porcupine stains. That's kind of the common name for it. That is where you can have capillary angioma below the surface of the skin, and it's going to have like a purple red appearance. They do vary in size and shape, you guys. That is what you see in that lower segment. A lot of the times, that will be on the face, like you can see there. It can be pretty extensive. It usually doesn't blanch or disappear. I know my husband comes across a lot of those.
Yeah,
in
they
the
do laser. Do they do laser treatment on it?
Laser
Yeah.
treatments could be helpful to help reduce some of that appearance. And then erythema toxicum. This is a pink rash that can appear suddenly anywhere on the body of a term newborn during that first 3 weeks. We call it just like a general newborn rash. There is no treatment for it, so we just let parents know that it will resolve on its own. Sutures, molding, and more. So try to remember the differences, especially between the caput and the cephalohematoma, okay? Because that is where I found like a lot of your questions. I know you went through the dynamic quizzes too. I felt like it was like wanting you to know the differences between which one crosses suture lines and which one doesn't, okay? So with that said, which one will cross suture lines? Looking at those pictures. The caput will cross those sutures versus the cephalohematoma, which is that lower one, you can see does not, okay? So that's something just to know about those two especially. And then cephalahematomas. So do you think if we have a cephalohematoma that that's going to put the baby at an increased risk for some elevated bilirubin? What do you think? It can. Okay, so that was something else I came across too, is just know that that can increase the baby's bilirubin slightly, okay, because that is extra blood that is going to need to be broken down. So therefore, it could increase that bili level. Good. Eyes and ears. So I'm just going to briefly hit this stuff, you guys. We should look for symmetry and shape. Each eye from the inner to the outer campus and space between the eyes, this is really confusing, should equal 1/3 distance across both eyes to rule out chromosomal abnormalities like Down syndrome. Okay, so really the main things is like assessing where those eyes are in relation to the ears too, okay? Because if those eyes, the corner of the eyes, if you're like measuring where those corner of the eyes come to in relation to the ears, and they're sitting kind of, you can see here how those ears are lower set here, that is an indicator of Down syndrome. Okay, so that is one of the big things to know about that. And then go back real quick. The other thing that I wanted to talk about with the ears too is that cartilage should be firm and really well formed. Or excuse me, cartilage that should be firm and well formed, because if it's not, then it's going to indicate that prematurity. Okay. And then the last thing with the eyeballs too is just making sure that we have that pupillary and the red reflex present. Nose, so it should be midline, flat, broad with lack of bridge. Mucus should be present, but no drainage. Remember, are babies obligate nose breathers? Yes. Okay. So they don't develop that response of opening the mouth with nasal obstruction until 3 weeks after birth, okay? So nasal blockage can then result in that flaring of the nares, cyanosis, asphyxia. So we want to make sure that we are educating parents about babies being those obligate nose breathers. And then again, that kind of does that education aspect too. And then sneeze to clearing nasal passages. So babies oftentimes try to sneeze out to clear out that drainage if they have excessive drainage in their nose. Mouth, making sure that we assess the palate closure and the strength of the sucking, okay? Lip movements should be symmetrical when we're looking at it. Saliva should be scant. If it's excessive saliva, that can indicate a tracheoesophageal fistula. So that is just one clinical finding that we could find with that. Epstein pearls are these kind of like white little cysts or like circular things in the mouth. You can usually find it on the soft and hard palates and gums, and that actually can be normal, you guys. So that is just an accumulation of epithelial cells, and that will disappear on its own. There's like no treatment for it after a few weeks, okay? So if some patient, you know, comes in and is concerned about that, just know that that can be a normal finding. The tongue should move freely, should be symmetrical. There should be no protrusion. If there is, what could that also indicate? What could that be a sign for? Which chromosomal abnormality? Anyone know? Tongue protrusion? Down syndrome, okay? Soft and hard palate should be intact. And then gray-white patches on the tongue can indicate thrush, a fungal infection. So that could be caused by vaginal secretions. So that is something that we might want to assess for, okay? Right. Everything okay online?
Yep, someone was
Okay.
asking if it was being recorded.
Oh, perfect. Newborn assessment, neck, chest, and abdomen. So real quick, I just like briefly hit these topics. Know that short, thick, surrounded by skin folds. There should be no webbing of the neck, okay? Moves freely from side to side and up and down. Absence of head control can indicate prematurity or Down syndrome. So if they're not able to control their head very well, we might want to look into that further. The chest should be barrel-shaped, respirations, primarily diaphragmatic. Clavicles should be intact. We should not see retractions. Nipples well-formed and symmetrical, and breast nodules 3 to 10 millimeters, okay? Abdomen, umbilical cord should be odorless, exhibit no intestinal structures, should be round, dome-shaped, non-distended. Bowel sounds present within few minutes following birth. So know all of these normals, okay? Because then if you come across something that doesn't fit in that category, you know that it's abnormal. So that will help you when you're thinking about your test. So I'm showing you everything that's normal to help you then identify what could possibly be abnormal, okay? Extremities and spine. Assess that full range, symmetry of motion, spontaneous movements. Those extremities, like Lindsay was saying earlier, they should be flexed, you guys, okay? We're wanting to assess for both legs and flat feet. Should be present because lateral muscles are more developed than the medial muscles. We should have no clicks when we're moving those legs to assess those hips. The gluteal folds and the back should be symmetrical. Okay, those lines on the babies, like on the back of baby, should be symmetrical. Soles should be well lined over 2/3 of the feet. Nail bed should be pink, no extra digits. And then the spine should be straight, flat, midline, and easily flexed. If protrusion of meninges or the spinal cord is noted, that's going to indicate what? Spina bifida, okay? Sometimes a deep sacral dimple needs to be further investigated if we see that on the baby to rule that out. These are the normal newborn reflexes. Rooting, what's that? What's the rooting reflex? Got to be familiar with these. Yeah, I see you kind of moving your head. So when the baby, yeah, if you like brush the cheek, the baby is trying to go towards the breast. That is the rooting reflex, is when they're turning towards which side you brush them, okay? Sucking reflex, where we're kind of sticking our finger in and they're able to suck effectively, okay? Because we want to make sure that they're able to breastfeed properly. Palmar grasp, that one. Okay, so plantar grasp, what is that? Oh, sorry, for those online, what we're doing is sticking a finger in the palm to see if they close or wrap their hand around it. Plantar grasp, what are they gonna do? What's that one? Yeah, is that one? You guys think? Yep, so careful. One of them is Babinski. Okay, so which one is Babinski? That's the one where we're gonna do almost like, you say it's like a J, right? A J.
If they fan their toes.
If they fan their toes out, okay? Now, is that the same finding that you would get in an adult? Nah, it's opposite, okay? The stepping reflex is going to be where we have the baby upright. And when you kind of put them onto a flat surface, then all of a sudden they're going to pick up their foot as if they're like taking a step. So that's why we call it the stepping reflex. We just talked about the Babinski one. That is where they're going to fan out their toes. If we do that J, you do have to use a decent amount of pressure on their foot. Okay. Tonic neck reflex. This is also called the fencing reflex. So that is where what? Think about fencing. Is the baby gonna, like, if you turn that baby, it should almost like invert. So if we're turning the head, if baby's laying and it's turning this way, we do the fencing reflex because it's gonna almost be like, oh, like it's gonna be fencing. So that is something I want you to think about with that tonic one, is the fencing, because all of a sudden it's just going to be on guard as if it's like fencing an opponent. Moro, that is also known as the startle reflex. So it sounds cruel, but you guys, it's not like we're dropping the baby from really high up. You literally just lift the top portion of baby when they're in like even a bassinet, and you lightly just let go of them. And as they're going back, you should see that they're like panicking because they're like, whoa, what's happening? I don't know where I am. Where are my surroundings? So you should kind of see a movement within those extremities. And that's what we're looking for with that Moro reflex. And then trunk incurvation is when we're kind of putting our hand, like kind of following along that spine, and the baby kind of like curls with how we're moving our hand. I wish I had pictures on there to kind of show you, but just know that that one is with the spine one, okay? Labs. Labs are hard, okay? And I don't know if ATI gives you normal ranges. I'm guessing not, okay? So this is honestly something that you guys just have to memorize, especially when it comes to your glucose levels as well as your bilirubin levels. Those ones are going to be pretty important, okay?
I feel like those might be the only two that they test.
I do agree.
Yeah.
I think those ones are going to be the main ones where they want you to know what is normal for that glucose range. Excuse me. And then what's normal for bilirubin. Keep in mind, you can see there for bilirubin, 24 hours, it's 2 to 6, 48, 6 to 7, and then 3 to 5 days, it drops again to 4 to 6. Okay. So that's where it gets tricky, and that's just pure memorization. Heel stick. So I do feel like you might get a question on how to do a proper heel stick, because remember, we are going to want to do a heel stick to do that metabolic screening, you guys, on those newborns, because that is required and mandated in all states. So that newborn should have eaten for at least within that 24 hours to make sure that that exam is accurate when we do that heel stick and get that blood sample. All states are also going to require testing for PKU defect in that protein metabolism. So that is something that we're going to just want to educate the parents of. And this is where it's like a paper and it's going to look for a ton of different like chromosomal disorders or abnormalities. And we send it off to the state. And then I can't remember the time frame or the turnaround for that, but we should be getting results. I'd say it's like at least within a week of if anything came positive back on that test. So another one that they're going to test for is like cystic fibrosis on there. So that's the one in the classes that I had with you guys. I talked about how my daughter was positive for CF. So that's what kind of led to us having to do all of her genetic testing and stuff like that. Is because she had a positive metabolic screen result for that CF. Okay. So when we are collecting that blood sample, know the tips and tricks to be able to get an accurate blood sample. So you do want to warm that newborn's heel to increase the circulation, cleanse that area, and then let it dry. Okay. And then we're going to use a spring activated lancet. So skin incision is quick and painless. The outer aspect of the heel should be used, and we do want to apply pressure after the heel stick, so that way we can decrease the bleeding afterwards, and then provide comfort and cuddles. So that is how your ATI worded it. So I put it there because I do feel like you might get a question on something like that, okay? Again, glucose, so the normal levels there, so 40 to 60. Normal glucose levels, is that different from the other one, I feel like? Go back, Lindsay, to the other lab page. Okay, just wanting to make sure. Okay.
Yep, because it starts to go up after.
All right.
Too.
So I just wanted to make sure they were consistent. Normal glucose level days, 50 to 90. If low, we do want to confirm with lab specimen, less than 45s, okay? If they are low, it could be due to large for gestational age, small for gestational age. Maybe we had a diabetic mother, maybe they are preterm. Hypoglycemia can cause seizures, brain damage, and cold stress. So it is really important that we act on those lower blood sugars. Some signs and symptoms of that hypoglycemia, you guys: poor feeding, jitteriness or tremors in the newborn, weak cry or apnea or irregular respirations, hypothermia, lethargy, flaccid muscle tone. What does that mean? Okay, like there's no muscle tone. Cyanosis, seizures, and coma. Treatment, we're going to encourage oral feedings and recheck after feedings. Symptomatic newborns, we're going to initiate that IV dextrose protocol, and then we're going to monitor that blood glucose closely and maintain skin-to-skin contact to treat the hypothermia. Phototherapy for hypobilirubinemia. Okay, so if we're having to do phototherapy for babies that do have that excess bilirubin, we do want to make sure that we're monitoring those vitals. For those babies that are under those lights, we do need to maintain an eye mask over the eyes to protect the corneas and the retinas. So that is something that we need to think about. You do want that newborn undressed, okay? So that way all of that skin is being exposed to that light. We do want to cover genitalia on males, though, to prevent testicular damage from the heat and light waves. So oftentimes what they might do, according to your ATI, is take out the metal strip from the eye mask, and then they might place that over the newborn's genitalia to keep the light from getting to it. So that would be something, is if you were going to use an eye mask, making sure to remove that metal piece so it doesn't get warmed up from the light and cause a burn to the baby.
I've never had an eye mask with a metal piece, and they just wear their diaper.
Yeah, this is ATI.
Oh.
So I just wasn't sure if you guys would get a question. So I literally pulled that straight from your ATI book. Okay. I know most of the time you do keep a diaper on them. So I don't know why they would try to manipulate a mask around it, but hey, whatever ATI wants you to know.
Throw it in a tube sock.
Yeah. avoid lotions and ointments, you guys, because those can increase the absorption of that heat and could lead to burns. Remove the newborn every 4 hours, unmask, check for any inflammation or injury. Reposition the baby every 2 hours to make sure that we're exposing all those body areas, those different surface areas to the light and prevent pressure sores as well. Check lamp energy with the photometer per your facility protocol, and then turn off lights before drawing blood for testing. Continuous observation with this, we do want to make sure that we're observing those newborns for any effects of that phototherapy. Just know bronze discoloration is not serious, and that can just be something that you observe. Same with a maculopapular rash that can develop too from that phototherapy, and it's not considered a serious thing, but can be a side effect associated with that. Development of pressure areas, that might be because we're not rotating our baby enough. Dehydration, so we do want to keep an eye on that, making sure that we're monitoring output, those mucous membranes. And then if they're starting to get an elevated temperature, that's telling us maybe too that baby, those temps might be a little too high. You might want to adjust those, take a look at that. Your phototherapy, what do you call it, machine thing, make sure that those are adjusted properly. Encourage parents to hold and interact with the newborns when the lights are off. We do, again, want to monitor weights, elimination for any of those signs of dehydration. Checking that temperature every 4 hours during phototherapy to make sure that we're watching to see if we see a rise in that. Making sure that we're feeding that newborn frequently and early, you guys, at least every 3 to 4 hours, because remember, that's how bilirubin leaves the body, okay, is through the release of them voiding and then also stooling, okay. Explain stool contains bile and will be loose and green because of that breakdown and that excretion of that bilirubin. And from the lights there, newborn's bilirubin should start to decrease within 4 to 6 hours after we start treatment. So if parents ask, it will take at least 4 to 6 hours before we start seeing those numbers trend downward. The Ballard scale, you guys, how are we doing on time here? 11:18.
Yeah.
So I'm not going to hit too much on this. I did put a, oh, indeed I am, I guess my watch says. So I did put a video on there. If this is something that confuses you, I did find a really, really good video. So that is actually accessed through your ATI. So it is an ATI video. And so that would be something really good to watch if you feel like you need to know more about that Ballard score. This is something that we're going to do to assess their neuromuscular system and physical maturity to help us determine their gestational age. So please use that link if you feel like you need to have more information on that or want a better review. Classification after assessment. So these are the different terms that we would use to identify different babies of like either appropriate for gestational age. That weight is going to be between the 9th and 90th percentile when we're looking at those charts, those growth charts, and how we chart babies' weight and their length. And is there something else too?
Chest circumference.
Head circumference. Yep. Chest circumference and the head circumference on there. So depending on how they're tested will tell us where they're at on that growth chart too, okay? And those are the different terms to look at. Newborn pain assessment. So make sure that we are trying to look for any signs or symptoms that maybe that newborn is experiencing some pain. So some responses that we might see in the baby are alterations in that sleep-wake cycle, their feeding or their activity, fussiness or irritability, limb withdrawal, thrashing or fist clenching, muscle rigidity or flaccidity, facial grimacing, chin quivering, furrowed brow, tightly closed eyes, open or square-shaped mouth, crying, groaning, or whimpering vocalizations. So there is a really good example of what a baby might look like if they're experiencing pain there, okay? Vital signs, skin, lab findings that you would see in response to pain. So I put those on there too, just to help you guys determine that. Newborn bathing, we won't bathe baby until that temperature is stabilized. Okay, so we do want to make sure that that temperature has been stabilized at least at 97.7. We do want to do a complete sponge bath, but we'll postpone that again until we have that stabilization at temp. We should wear gloves with that, you guys, to avoid exposure to those body secretions. And then make sure that we only expose one area at a time of that newborn. And then once you wet it and you clean it, then you dry it to prevent, again, them losing to excessive heat. Okay, so that is something else to think about. Newborn meds. Okay, so you can see in the image there where we would be giving those different injections that we have to give. Okay, so that is something to be aware of. We're going to be doing Hep B within 12 hours of birth. Okay, and then that second dose is going to be administered at 1 month. Third one at 6 months. Your vitamin K, we're also going to be given, okay, because remember those babies don't have the ability to clot yet until they can synthesize their own vitamin K. And then there's the erythromycin eye ointment. Remember, that is going to prevent blindness and conjunctivitis that could result from gonorrhea. Okay, so we always give that. Real quick, where are you going to put that ointment? Yeah, so you're going to kind of pull open and make sure that you're doing it within that inner lower lid there. Okay, so, and do we want to wipe it off straight away? No. Okay, so make sure that that is staying in place. Okay. Discharge teaching and safety. So making sure that they know we're aware of those different community resources. Okay. And things that can help those individuals, especially if they're first-time parents, to help with that ongoing education and assessment that they might need. Never leave in a newborn unattended with pets or other small children. Really important to inform parents of that. Obviously, keeping those small items out, because remember, babies learn by sticking things in their mouth. Okay, so they like to stick anything and everything in that mouth. So we got to avoid anything that they can stick in there, and that is a choking hazard. Never leave a newborn on a bed, couch, or table. Okay. Never place a newborn on their stomach during sleep during the first few months of life, because that can increase the risk for SIDS. We only want to do that when they're awake and supervised. We call it tummy time. That's okay as long as we are watching them. Never provide a soft surface to sleep on. That's a lot of S's. Nothing in the crib, firm mattresses, no bumper pads, no blankets. Linen should be tight fitting. It sounds like we are so strict with that. But again, those are all things, you guys, that increase the chance of SIDS. So that's why we tell them that. Avoid placing crib by window to prevent that cold stress by that radiation. Smoke detectors should be on every floor. Control the temperature and humidity of the home, making sure that the home is at an appropriate temp for the baby. All visitors should be washing their hands before they touch the newborn. We want to make sure that we are teaching them proper ways of holding their baby and discussing with them shaken baby syndrome. And then make sure that that car seat is in the back, ideally in the middle. And then that baby should be rear facing, okay, until at least the age of 2, or they reach that maximum height and weight. Then they can turn that car seat around. SIDS, we kind of hit quite a bit here. This is that sudden unexplained death of an infant younger than 1 age. You know, there's a lot of different possible causes. So we have just come up with this system to try to avoid this happening, okay? So again, that's going to be the stuff that was listed on that slide to help educate parents on. Secondhand smoke is a big one too. So make sure parents are aware of that, okay? Danger signs and when to call. So this would be things when the baby's not eating, they have large episodes of vomit, projectile vomiting especially is something we're going to want to know about. If they're not keeping up with the amount of wet and dirty diapers that we would expect based off of how many days old they are. or if they're having excessively runny, watery stool, because that's going to lead to dehydration very quickly in those little babies. Lethargy or difficult to wake, really important one. Prolonged crying, high-pitched shrill cry, okay? Very low or high temperatures. And then obviously if there's any oozing, redness, or foul odor around that cord, we need to know. All right. A nurse is caring for a newborn immediately following birth. Which of the following nursing interventions is the highest priority? Initiating breastfeeding, performing the initial bath, giving a vitamin K injection, covering the newborn's head with a cap. What do you think? Think breastfeeding? Any other options? You think which one?
Machine.
You think initiating breastfeeding? Lindsay, what's the correct one? Sorry,
It's
guys.
putting the cap on their head to decrease heat loss. But I go with you guys because if they're breastfeeding, their skin to skin, they're warm. But
Yeah. So the thing with this one is thinking about that regulation of temperature. Okay, so I mean, it does make sense because the baby would be skin to skin. Again, I put this on here because I wanted to show you guys how ATI is wording their questions and what they want you to think about. And it's making sure that that baby's temp stays regulated. One of the bigger ways of losing heat is through their head and through their feet. So if we're able to stick a cap on, that's going to decrease the amount of heat loss that's happening. Okay, that's their thought process with that. A nurse is caring for a newborn who was born at 38 weeks of gestation, weighs 3,200 grams, is in the 60th percentile for weight. Based on the weight and gestational age, the nurse should classify this neonate as which of the following? Low birth weight, appropriate for gestational age, small for gestational age, or large for gestational age. What do you guys think? Good job. It's appropriate. A nurse is completing an assessment. Which of the following data indicate the newborn is adapting to extrauterine life? Select all that apply. Expiratory grunting, inspiratory nasal flaring, apnea for 10-second periods, obligatory nose breathing, crackles, and wheezing. What do you guys think? What question is this? What do you think?
B.
B? Okay, anything else? So which one is saying that it's adapting to extrauterine?
so which ones are normal?
C? Anything else? All right, Lindsay, what's the answer there on there?
C and D.
C and D, guys. Okay, so remember that they are obligate nose breathers. Okay, and then apnea for 10 seconds is fine. That's actually expected. But if it's longer than that, then we need to be concerned. Okay,
It's gonna be normal. Parkinson.
That
that
would be abnormal.
that would be abnormal.
Oh,
Okay, so if we have crackles and wheezing, that would tell us that that's abnormal, that baby's not adjusting well to being able to breathe on its own.
C and D.
C and D for that one.
Oh, check.
A nurse is teaching a newly licensed nurse how to bathe a newborn and observes a bluish brown marking across the newborn's lower back. The nurse should include which of the following information in the teaching. This is more commonly seen in newborns who have dark skin. This is a finding indicating hyperbilirubinemia. This is a forceps mark from an operative delivery, or this is related to prolonged birth or trauma during delivery. A. So those are those gray spots that we talked about, also known as Mongolian spots, which your ATI still uses, but we will see probably some changes with that in the near future.
Do you guys all have class at noon? It is 11:30, so if you guys need to go to have lunch, yours is
Okay.
12:30. Okay.
A nurse is completing a newborn assessment and observes small pearly white nodules on the roof of the newborn's mouth. This finding is a characteristic of which of the following conditions? Mongolian spots, Melia spots, erythema toxicum, or Epstein's pearls. You guys are close because those are found where? Those are still white, tiny spots, but where are those ones? Yep, on the skin. Okay. Whereas the ones in the mouth are actually the Epstein's pearls. Okay. So I want you to think of like a clam having a pearl in it. Think about that as the mouth. So Epstein pearls, you would find it in the mouth. Okay. Because just like a clam shell would have a pearl in its mouth. So hopefully that would help. I don't know. That's how I always thought of it. A nurse is assessing the reflexes of a newborn and checking for the Moro reflex. The nurse should perform which of the following? Hold the newborn vertically under arms and allow 1 foot to touch table. Stimulate the pads of the newborn's hands with stroking or massage. Stimulate the soles of the newborn's feet on the outer lateral surface of each foot, or hold the newborn in a semi-sitting position and then allow the newborn's head and trunk to fall backward. Yes, D is the correct one. Good job. A nurse is preparing to administer a vitamin K injection to a newborn. Which of the following responses should the nurse make to the newborn's parent regarding why this medication is given? It assists with blood clotting. It promotes maturation of the bowel. It is a preventative vaccine, or it provides immunity. It assists with blood clotting. Yep, correct. A nurse is taking a newborn to a parent following a circumcision. Which of the following actions should the nurse take for security purposes? Ask the parent to state their full name. Look at the name on the newborn's bassinet. Match the parent's identification band with the newborn's band. Compare name on the bassinet and room number. The identification bands, okay? That's going to be a big one. A nurse is preparing to, sorry, do you have a question, Mukhtar? Yes. Go back, please. Thank you. This one here, matching the parent's identification band with the newborn's band. That's going to be the correct one there, okay? Always wanting to make sure that those bands are the same for both the parent and the baby. A nurse is preparing to administer prophylactic eye ointment to a newborn to prevent ophthalmia neonatal. I butchered that so bad. Which of the following medication should the nurse anticipate administering? Erythromycin, yep. A nurse is reviewing care of the umbilical cord with the parent of a newborn. Which of the following instructions should the nurse include in the teaching? Cover the cord with a small gauze square. Trickle clean water over the cord with each diaper change. Apply hydrogen peroxide to the cord twice a day, or keep the diaper folded below the cord. Yep, keep the diaper folded below the cord. So that cord should not be inside the diaper. Okay, good job. A nurse is caring for an infant who has high bilirubin levels and is receiving phototherapy. Which of the following is the priority finding in the newborn? Conjunctivitis, bronze skin discoloration, sunken fontanelles, or maculopapular skin rash? Which of the following is the priority finding in the newborn? Good job. The sunken fontanelles. Because what is that telling us? Anyone know what sunken fontanelles are telling us? Excessive what? Shouldn't say like excessive, but could be severe dehydration. Okay. A nurse is called, excuse me, to the birthing room to assist with the assessment of a newborn who was born at 32 weeks gestation. Newborn's weight is 1,100 grams. Which of the following are expected findings in this newborn? Lanugo, long nails, weak grasp reflex, translucent skin, plump face. What are your thoughts?
Okay.
Okay. Got A. Thinking C. Okay, anything else? All right, Linz, what do we got for that one?
It is lanugo, weak grasp reflex, and translucent skin.
You guys were really close. I was seeing if you were getting it, and Mukhtar, I feel like you were thinking about it, but you weren't sure. So that's A, C, and I think it's D is the other one, right? A nurse is caring for a newborn who is preterm and has respiratory distress syndrome. Which of the following should the nurse monitor to evaluate the newborn's condition following administration of synthetic surfactant? Oxygen saturation, body temperature, serum bilirubin, or heart rate? What do you guys think? Oxygen saturation? Yeah, because what are we gonna be giving them for that surfactant? What do we give preterm babies to help with surfactant development?
What do we give mom
Or mom, yeah, thank you.
when she's in preterm labor?
What is that med we're gonna give? Test your guys' memory here. Beta.
Wait about this one. Yep.
Nurse is reviewing car seat safety with the parents of a newborn. Which of the following instructions should the nurse include in the teaching regarding car seat position? Should it be front seat rear facing, front seat forward facing, back seat rear facing, or back seat forward facing? Yes, good job. C is the correct answer.
Did it. That's it.
Woo!
Woohoo!
And I'm only 7 minutes over. Wow, I must have cruised through that podcast. So hopefully it will help you guys get through the content. You now all have access to the recording, to the PowerPoint, if you have questions or want to go back to anything, okay? Let me and Lindsay know, otherwise, if you have any other questions that come up. So hopefully that will help you guys be successful.
Yeah.
All right, we can stop the recording there too.
How do I stop the recording?
Oh,
All right. Go here. Stop.
Thank you, everyone.